Welcome to the exam analysis of INICET November 2025 exam. I know all of you are tired. You have been traveling since yesterday. You have been making makeshift arrangements in some new city, settled down on a relative's house or a hotel, traveled early morning to the center of your exam. Some of you were on time, some of you were running late, some of you were the last person to enter the exam hall. Everybody with an orange band in their hands, and everybody with a very, very rich experience with them that the INICET November 2025 exam has given you all. So welcome to DBMCI MDS. I am Dr. Himani Joshi, the original guru for oral and maxillofacial surgery and the academic director for DBMCI MDS. And today we will analyze how the exam was from the perspective of every student and every teacher. Lot of you were giving this exam for the first time. Lot of you have been giving it for the second or third time. यार ये क्या waiting है? Sorry for that lag. So, most of the students came out of the exam hall smiling, okay? Especially the ones who have given it for the first time. Now, if we talk about the pattern of exam, good evening, Siddharth. Good evening, Aparajita, Siuli, Shlok, SP, Saurabh, Ramya. I know. You are not able to sleep. Saurabh is saying I was not able to sleep because of a lot of anxiety. The recall will give you more anxiety. But the good thing about recall is whatever anxiety happens today, tomorrow, and is over. Okay? It's an experience. Always remember, no exam is bigger than life. And every exam is an experience which will teach you something very, very important for the next exam. All right? So everybody who is anxious, everybody who is upset that I've read this question or I know this topic, still my answer got wrong, or it was a fluke and my answer is got correct. Just don't think. All right? Just take the answers, just listen to the answers, just take it as it comes and learn from it. That is all you need to do. NEET is your main game. All right? So let's begin with the exam analysis here. First of all, we talk about the pattern of exam. I will say that the pattern was the old AIMS pattern. What is the old AIMS pattern? Old AIMS pattern means very less basics and much, much more clinical. We have seen that initially the AIMS exam which used to happen used to be full of questions from the branches that AIMS has. Ortho, pedo, perio, endo, PhD and oral surgery. These 6-7 subjects were the crux of the paper in the old times, and this has been repeated this year. Till last few exams, there used to be a mixed bag of questions, including subjects like biochemistry, DADH, but this time there were no questions in biochemistry, no questions in DADH, very, very few questions even in medicine, 3 questions in physiology. So basic, yes, anatomy had good 9 questions, but basic paper was very, very less. Majority of the paper was clinical, including PhD. Now, I count PhD in clinical because it's one of the very important branches in AIMS, and AIMS being an institute of national importance, taking decisions for the country's dental programs, PhD is a very important subject. So again, we have seen that the pattern has gone back to the old pattern. So less basics, more clinical. Compared to the last few exams, there were very less image-based questions. Just a few in anatomy, 1 in pharma, few in prostho, And other than that, very, very less image-based questions. 2 or 3 classification-based questions, which were very, very basic. Classification-based questions like the Kennedy's classification or the Ellis-Davy classification, just the routine classifications that we read in our basic studies. Okay, and AIMS favorite subjects. As always, I mean, these subjects will always have a lot of questions. Okay, there can be few less, few more, but ऐसा कभी भी नहीं होगा कि इन subjects से maximum questions नहीं आ रहे हो. And it remains the same. Cons endo, and when I say cons endo, it includes dental materials. Dr. Aishwarya has already compiled around 35 to 40 questions from cons endo DM. PhD, another favorite, 30 questions. Oral surgery, around 11 questions. Ortho, around 17 questions. And pedo perio, OMR, oral path, few questions. All right. So these have always been the AIMS favorite questions, and this year again, it was the same trend. Okay. If I talk about PYQs, I've always said one thing, whenever students ask me that, ma'am, what is the most important thing, or, how we should study. One second, there's a little pause there. All right. So there was a little shadow there disturbing the class. Okay. So they asked me, ma'am, what is the most important resource? And I've always told you that PYQs is your most important resource. Everybody who has given the exam today will realize that around 50 to 60% questions always are asked from PYQs, and the trend continues. This time I think it was even more. The PYTs and PYQs had around 70% questions. I mean, most of the questions you would feel that ये पढ़ा हुआ है, देखा हुआ है, कहीं तो भी हमने, we have read about it. Maybe you knew the answer, maybe you didn't know the answer, maybe you got confused, but at least they were the questions which you have seen. All right, so again, the trend of PYQs and PYTs being asked continues. All right, no questions were there from COVID. This time there were no questions from COVID. As expected, COVID is a history now. It is of the past, and the AIMS has not asked any questions of COVID. Surprisingly, no HPE or any oral path, general path slides. So AIMS has recently given a lot of importance to histopathological diagnosis. If you see the last few exams, you will see that a lot of slides have been asked, whether they are stain-related slides or immunofluorescence-related slides or simple H&E stain-related slides where they've asked about diagnosis or management. So this time, surprisingly, there were no slides in the question. That were typically, I mean, the description was there. There was cribriform pattern and Swiss cheese pattern and these kinds of cells, and all these description of slides were there, but image-based questions of slides were absent. That was a little surprising because we were expecting some of such questions in AIMS. New questions. Coming to what was new. So till now, we have seen whatever was repeated from the old AIMS pattern. What was new was clear aligners. Clear aligners is one topic which is recent, which is trending in ortho, and not a lot of questions are asked previously from clear aligners. Sorry. And this time, lot of questions on clear aligners were asked. Okay, at least 3-4 questions which we could identify from clear aligners. Prostho, the trend continued from CD to RPD to FPD to implants. And implants is not new. Okay, implants have been asked previously in both INI and NEET, and the trend continues. Implant questions were still there this time. Clinical correlation. Now, this was also, it is not really new. It has always been asked, and this time the trend continues. Lot of clinical correlation. And examiner always goes one step forward. So maybe if he has asked some topic previously, he will go one step forward and ask about one extra step. The question of en bloc resection. So we have all read about en bloc resection. But what they asked was the design of en bloc resection. So if you give it a butt shape, it will cause fracture. If you saucerize it, it will not cause fracture. And that was put into a clinical scenario-based question, and that was asked. All right, so this is not the routine factual or conceptual question. This was an extension of the clinical based question, which makes the paper a little difficult. So this has made, these few things have made the paper a little difficult. And the fourth thing, so first is clear aligners, second is implants, third is clinical correlation, and fourth is, of course, PhD. Extreme number of questions in PhD. Last section was almost completely PhD, and students were anyways getting apprehensive, saying that, you know, it is too difficult to finish PhD questions. Some were new, some were repeated, some very easy questions like hierarchy of evidence, meta-analysis, and all those. Lot of inheritance-based questions. Thalassemia trait, incomplete penetrance of disease, prenatal genetic testing. So a lot of questions on inheritance. Excuse me. We'll just pause here for a minute. Pause करो. Pause करिए. Pause कर दी. All right, coming back. Sorry for that pause. It's grab 2 in Delhi and extreme pollution. So I'm sorry for that break. So inheritance-based question, although we have taught them in detail in pathology, but 3 questions based on inheritance were also something a little new, which is made the whole paper into a little bit of variety with PYQs and the new questions. Okay. Coming to individual subject-wise description. First was anatomy. Anatomy had around 9 questions and they were moderate. Some were very, very straightforward, like Horner syndrome due to the cervical sympathetic ganglion. Internal carotid artery aneurysm causing the lateral rectus paralysis due to abducens nerve palsy. 3 image-based questions in anatomy showing the ventricles, showing the muscles, and showing the different bones. Okay, the 4 bones, temporal bone and ethmoid bone, maxilla and zygoma, and the first pharyngeal arch derivatives being asked. So broadly, some questions were a little tricky. Otherwise, most of the questions were straightforward there. Physiology, very, very random 3 questions. Question on trypsin, question on cells in the cerebellum, which is the Mosey cells, and another question on thermal regulation of the body, that if the temperature of the body increases, how does the body regulate? So physio also 3 odd questions. Like I said, biochemistry, there were no questions, 0 questions in biochemistry and 0 questions in DADH. Again, bringing us to the old exam pattern where the small non-clinical subjects are not asked much. Coming to the second year subjects, patho-micro. Combined, there were around 5 to 6 questions. Like I said, questions on inheritance, questions on very easy questions like opportunistic infection by Candida, oral hairy leukoplakia causing AIDS, and straightforward questions in patho-micro also, most of them. Pharma. Pharmacology questions were around 8 questions, 7 to 8 questions in pharma. Mixed bag. Questions like oral therapy for, oral bisphosphonate for osteoporosis. Questions like T receptor dependent calcium channel blocker, or the potassium sparing diuretic with the maximum potency. One image-based question of first order kinetics. So all these questions made pharma a little difficult. Okay, so pharma was a little moderate to tough. But otherwise, most of the rest subjects till now, they were moderate. Coming to dental materials and cons endo. Why I'm taking cons endo here is together they had around what? 39 questions. We've been able to find around 35, 38 to 39 questions in DM Endo, making it one of the most important subject. So all those who have their cons endo strong, all those who have heard Dr. Aishwarya's videos, I'm sure you must be really happy with the cons endo questions. Questions were easy also, some classification based questions. Some questions were exact repeat questions from the previous INI. Questions on CAD CAM, questions on irrigation, questions on air abrasive systems. They were a direct repeat. So all those who have done the PYQs, all they've seen the DBMCI old recalls, you must have answered cons endo nicely. Coming to oral path, like I said, no slides, direct questions of CEOT, questions on adenomatoid odontogenic cyst, unilocular rhodolucencies, questions on multiple myeloma. So easy, straightforward questions. Oral path, not tricky. 3 to 5 questions in oral path, not so tricky. Medicine. Again, medicine, we have shortlisted around 4 questions in medicine. Questions like, which is the emergency drug for cardiac arrest and anaphylaxis? So epinephrine. ATT therapy, how would you do a routine dental procedure? So you would wait for 2 weeks. And simple questions, phenytoin, or, it doesn't work in which kind of seizure. So all these basic questions, some might find it a little difficult, but most of the questions were seen and heard of. General surgery. General surgery, we have identified 5 questions. And a lot of questions in general surgery were cancer-based. Okay. Stage 3 oral cancer, TNM classification. Perineural invasion, which cancer requires resection of the nerve and nerve canal. And all these necrotizing silometaplasia-based questions. And one question which always comes in general surgery is, suture. One suture question will always come, either in NEET or INI, which of these is a non-resorbable suture. So general surgery also, I think most of the questions were such that you have listened, you have heard, you have read them somewhere. One special subject which we teach here at DBMCI is general anesthesia. Although you can put this question in oral surgery or general surgery also, but one question of rapid sequence intubation, oral intubation in a case of polytrauma. We'll discuss the answers tomorrow when we do the recall of oral surgery, but one question was there which can be purely called as a general anesthesia question. Rest dental subjects, OMR. Yes, there were some image-based questions in OMR from CBCT to radiographic diagnosis. Around 6 to 7 syndrome-based questions. Ehlers-Danlos syndrome, nevoid basal cell carcinoma syndrome, and Perry-Robin sequence. So straightforward questions, no thinking. I mean, anybody who says that syndrome questions were difficult, then I think they lacked their preparation somewhere. So syndrome questions were straightforward, very, very scoring questions. So we have discussed them in morning motivation sessions. We have discussed them in revision sessions. So everybody who's made syndromes correct, you'll be a very high scorer in this exam. So syndrome-based questions were a lot. Benz-Jones proteinuria in multiple myeloma and all those easy questions. Next was oral surgery. 11 questions. Some were straightforward, like, maximum amplification of forces in a crossbar elevator, or, in intraligamentary injection in a hemophiliac. So these were straight BDS level questions. Some were really difficult. Some were typical questions of, like I said, the resection, the end block resection question, which is a little tricky. The BSSO positional screw question, that was a little tricky. And some absolutely repeat questions like, the fly fluorouracil wala question, which was repeated from the last INI. So mixed bag of repeat questions, mixed bag of new questions, clinical questions also. Next, we come to prostho, and like I said, prostho was a big bulk of the exam. Around 20 questions from all the segments in prostho. Some very easy, like the healing cap of implant, or the Kennedy's classification, or the muscle which is causing the lingual flange in the impression. Some little difficult questions also in prostho. So mixed bag again in prostho. Ortho, like I said, around 11 questions in ortho, and some difficult questions. Okay, so clear aligners, a new topic. Myofunctional, some myofunctional questions were also new. So this was a little difficult. And pedo, around 10 to 11 questions. They were easy as per the students who have given us a feedback. Perio, around again 10 to 11 questions. Some were absolutely bang on. The question of fenestration and dehiscence, which is there, the image-based question of fenestration and dehiscence. I think since the last 15 or 20 years, that same image has been coming in exam, that same image. Not even the image is changed. So when you see such a question in exam, you feel happy that at least there are certain things that stay the same. So I'm sure all of you who have given the exam, you were very happy when you saw that Perioka question of fenestration, dehiscence, legend, crater. And I'm sure most of you have marked it correctly also. So such questions, give a lot of confidence to you that if you read the PYQs, if you read the previous year questions properly, you will be able to score well. Even if you are selected or not, you will be able to score well. And that is the purpose of INI. To tell you that, all you lack is revision. You have done the reading, you have done the concepts, you've understood the concepts. All you need to do now is to revise. All right? And last but not the least, PhD with good 30 to 35 questions. It was difficult. PhD was definitely difficult. It was lengthy. It was lengthy because it was also in set 4. It was in the last set. Most of us were tired by the last set. Most of us were anxious by the last set by the questions that we didn't know. Some questions were straightforward, highest level of evidence is meta-analysis. Some new questions also wherein a lot of, journals names were written and they were cross-linked and what kind of, cross-linkage is that. So definitely PhD was a little bulky. Now, after our in-house doctors and after our own DBMCI team did this exam analysis, like every year, we floated a Google form, which is also here in your YouTube session. You can all fill this form here. But before this, we have also taken a response from a lot of students. Here we are able to see very few responses, around 17 responses. But this has continued after I've made this PPT also. It has continued and now we have around 800 responses. And most of the responses were similar. Okay, so the level of questions of INICET November exam was 82.4% students said it was moderate. Okay, 17% students felt it was difficult, but a majority of you were in sync with what we say, that the paper was moderate. It was not very tough. Of course, it was not very easy, but it was a moderate exam. So 80% students felt that it was a moderate exam. Did the previous year recall questions help? 94% students said yes. The previous year recall questions have helped. And this is not just now. Take any exam the last 10-15 years and you will see that around 60% questions are coming from the PYQs and PYTs. So when I say PYQs, it may not be the exact same question. It may be or it may not be. But the previous year topic will be repeated. All right, so if there is a question on impaction, maybe it is the exact same question, or maybe it is a tweaked question, but around the same topic of impaction. All right, so definitely around 60% questions were PYQs and PYTs. Honestly speaking, if you have felt that not so many questions were PYQs, then maybe you're not reading the right source of PYQs. There are some books in the market which are very popular and they have a lot of previous year questions put together. Like there will be questions from 1993 to 2003 which are irrelevant. When I say PYQ and PYT, which it means last 10-year questions, only the last 10-year questions. Anything previous to the last 10-year questions is irrelevant. Classifications change, protocols changed, drugs change. So anything which is older than last 10 years is practically not useful for such big exams like INICET and NEET, especially for INICET where, the trend is always to ask the latest things. And latest cannot be older than 10 or 15 years. So if you're reading from a source which has questions, very, very old questions, I think there is a time for NEET. You should change your source to any book or any app which has the latest 10-year questions. And that should be your main. I can see some students who have felt that repeat questions were less. So that's okay. The only problem is that you are probably not reading from the right source. So please choose your source wisely. Was the INICET paper lengthy? So more than 50% students said no, it was not lengthy. But yes, almost 50% students were saying that it was, yes, it was lengthy. Personally, I felt it was not very lengthy. Yes, the last section, because it was full of PhD, it became a little lengthy in section 4. But overall, it was manageable. If you have given your GTs properly, if you have had the practice of giving the INI GTs, then probably you were able to finish. See, it is an AIMS exam. It is not, it cannot be halwa. Okay, you can't expect it to be really, really easy and a piece of cake. So definitely it has to be tough. It has to be slightly, taking you to the edge. But considering the previous exams, which have been really, really lengthy and really difficult, this year it was not so much so that you were leaving questions. Most of you were able to mark all the answers, read at least once. Okay. Questions were asked from COVID or recent advances. So no COVID questions. Yes, recent advances, like I said, mostly clear aligners. That was something new. Inheritance, like we've discussed earlier also, these were new questions. High yield topics were asked in maximum subjects. Now this is very, very important. High yield topics. What are high yield topics? High yield topics means the topics which analysis says that the topics which are derived from the PYQs. I am very, very happy with the fact that 94% students felt that most of the questions or most of the subjects, the topics were the same. We have read, yes, I mean, some of you saying, like Henil Patel here is saying that 3-4 questions I found alien to me, like they were from another planet. Very true. Like even if as a faculty I sit for the paper, even I would say that yes, some questions were alien. We've never heard of and we've never seen. Yes, in a paper which has 200 questions of the AIMS level, if you have felt only 3 or 4 questions to be new, Henil, you've actually done well. All right. Even 20 to 25 questions, if you have not heard of or not seen, it's absolutely okay. Remember, the first ranker in INICET marks around, gets around 160 to 170 correct. Now, out of 200, if 160, 170 are correct, or maybe depending on the difficulty of the paper, I would say 150 to 170 correct. That means either he has done 50 wrong, 30 to 50 wrong, or he has left those questions. He or she has left those questions. All right. So even if you felt that around 30 to 50 questions were tough, or you got confused, or they were very, very clinical, and even in spite of the fact that you knew the topic, but you are not able to answer, or you have made mistake, it's absolutely normal. All right. Even the topper, the score is somewhere around 150 to 170 correct answers. All right. So don't worry. That's the crux. So this is the overall analysis. This is the overall subject-wise distribution of the questions. As a faculty, as a teacher of 12 to 15 years experience, what I would try to give you one message here is INICET November exam, is an exam to learn. I will take all your questions, don't worry. But primarily, the crux of this exam is learn from this exam. Learn the fact that if you know the concepts, it is not enough. What you need is revisions. You will remember the concept, but you will not remember the answer. To remember the answer, you need revisions. That is something we have to learn. First thing. Second thing, even toppers make mistakes. Even the first ranker will not have all the answers correct. So do not worry with the mistakes that you have made. Now, as we begin with the recall now in few minutes, which goes till tomorrow, you will find a lot of questions which are correct, which you didn't expect. Or a lot of questions which you thought were correct, but they were wrong. Don't worry. Everybody makes mistakes, including the rank 1. The agenda here is to learn. If you've made a mistake, learn from that, question and move ahead. And the third thing is The bigger game is NEET, which is still 2 to 3 to 5 months away depending on the exam's date. All right. So don't worry if your preparation was not up to the mark, or your exam you were having cold, or you were having fever, or you were traveling, and all those. You have learned from this exam, and that is what we really want. Okay. This is my take on the exam. This is my exam analysis. Now we'll take all your questions. Those who have questions, some of you are asking how should we revise. So Revision Pro is an excellent tool that the DBMCI MDS offers. Every subject covered in 7 or 8 hours, depending on the length of the subject. You sync that video with the DBMCI MDS notes. You get access to all the grand tests. You get access to all the important PYQs. You get the morning motivation. You get the doubt solving. And in the last 3-4 months, a lot of students previously have found the Revision Pro to be very useful. So if you are stuck, if you don't know how to revise, you can enroll into the Revision Pro program, and that will help you in your preparation for NEET. All right. And in the end, we will take your questions. Saurabh is saying, so nahi paaye exam ke baad itni anxiety ho rahi hai. See, it's day 1, day 2. For today, tomorrow, maybe one more day, you will have anxiety. Take a break. Go for a walk. Go for a small trip to some movie or some dinner trip, something like that. Take a break. Okay, this is one big exam. Take a break and then restart with a fresh mind. Okay, it's the first exam for most of you. So don't worry. It's a big all India level exam, very limited seats. Take a break and restart. Okay, anxiety will happen. I'm not saying that anxiety will not happen. Even I am anxious today as I'm doing the analysis and recall. It's okay. But take your time. Take a break. Take a small break and restart. All right. In this time, you can also watch the stories of the other toppers. You can go back to the DBMCI MDS Instagram page, and you can see how the previous year toppers, including Dr. Rudramurthy, Dr. Saurav Nair, or Dr. Anishka, or Dr. Sharvari, you can watch these interviews of the previous year toppers, and you can see how they have struggled, what they went through in the INI, what they went through, what were the depressing phases. You can watch their struggles. It will really help you. Okay, Saurabh, so I hope that helps you. Siddharth Gautam is saying here, समझ में ही नहीं आया कि पेपर easy था या difficult था. It is absolutely normal for a first timer or even a second timer who has just done a little bit of preparation and given the exam for experience. It can be possible that you cannot judge the difficulty of the paper. It is normal. So don't worry. It is okay. Slowly you will learn. Okay. SSJ is saying, I will secure 170 plus surely. Okay, SSJ, congratulations on that. You may be in the top 10 ranks of INICET in that case. Delilia is saying, PYQs are there, but not around 70%, around 30% only. Delilia, that means your source of PYQs is inaccurate. You should look at the right source of PYQs, which has a lot of previous year questions and topics, wherein you will realize that around 60 to 70% questions are repeated. Okay. Okay. Now there's a joke going on that I'll secure 170, 190. All right. Okay. Okay. So if there is any other query, any other doubt, what is the seat matrix for INI exam? So the latest seat matrix, one of the seat matrix is already there on the INICET, on the AIMS exams.edu.in website. You can go there and check. And the modified seat, that's a provisional tentative seat matrix. The modified matrix will be out soon, depending on the available seats in every institute. That will be coming down with the results. All right. Is there a way where we can utilize the PYQs alone from the DBMCI app? Yes, you can take the basic plan, the basic plus plan. It has only the questions and tests. So if you want only the questions and test series, Then you can take the basic plus plan. The cost is also very, very low, and you can take it till your next NEET or INICET, May INICET exam. So yes, that is the plan for you. All right. Should we mug up or understand? Now, Aman, that's a very good question that you have asked, that PYQs, should we mug up or understand? If you begin your preparation at the right time, so even this time is a good time. If you begin your preparation now, you have enough time to read the explanation of every question and understand each and every last 10-year PYQ nicely. That will bring you from an average performing level to an above average performing level. All right. Even mugging up the PYQs helps a lot, but that may or may not give you a government college seat. If you understand the PYQs, and we always stress on understanding, because now repeat question does not mean exact same question. It means the topic is repeated. So I will never say that just mug it up. Always understand. Rule out the other option, that if C is the answer, then why not A, B, and D? You should be able to eliminate. Elimination is very important. If you are able to eliminate, see, even in this exam, okay, there was a question on bone tapping, okay. Suppose you have never heard of bone tapping, okay. There was a question on bone tapping is done in what kind of bone? Dense bone, osteoporotic bone, porous bone, and hypomineralized bone or demineralized bone, okay. Now this question looks very alien. It looks like, oh, we have never heard of bone tapping. But honestly, if you just give few seconds to the options, you will realize that 3 options, bone is porous. 1 option, bone is dense. One is osteoporotic, demineralized, and something like that, porous bone. So all the 3 options are of one type, that bone is weak, less dense, and only 1 option is dense bone. So automatically, out of elimination, it becomes a correct answer. All right. Aman, I hope that answers your question, beta, because NEET is not just an exam of knowledge. It is an exam of smartness, both NEET and INI. It is also an exam of discipline. It's an exam of smartness. You know, just using your logic and using your common sense in the right place. How will that happen? That will happen only if you do the PYQs again and again and again. And you try and eliminate the options. Achha, ye nahi aa rahe, ye three options are same hai. You know, all these 3 options are the same. They mean the same. And even in this paper, as the faculties will do the recall, you will realize that lot of questions, you know, around 10 to 12 questions could be answered just by elimination alone. All right. So learn to eliminate when you do the PYQs. It will really, really help you. Okay. Tejas is asking me where to find the previous year questions. Like I said, the DBMCI MDS Basic Plus plan will give you all. See, all plans give you questions. If you've already taken a plan somewhere else, you want only questions, you can take the Basic Plus plan. Or if you want complete revision package, you can take the Revision Pro package. All right. When is the NEET going to happen? Now, I don't know the answer to this question. Last year, it was in the first quarter. It was in March, April, wala quarter. We are expecting and hoping that it is the same. But then again, it is not predictable. Okay. So, do what is in your hands. Do what is predictable. Study. Revise. Whenever the date comes, it will be the same for everybody. Everybody will have the same time. Okay. So, don't worry about the date. Just, just pay attention to revising the PYQs again and again. All right. Is 180 a good attempt? Shailesh, it's a very good attempt. If you have marked 180 correctly, or even a 150 out of 180 are correct, then it's a very, very good attempt. Basharte wo sahi ho. All right. Okay. Will I get a good rank if I start my preparation for NEET now? Again, that depends, Sri Lakshmi. That depends on how well prepared you are. If you have done your first to final year properly, if you have the basic concepts with you, then even 4 or 5 months is enough. If you have 0 concepts, if you have no basic knowledge, if you don't remember anatomy, physiology, then it's slightly less time. But, you know, like they say, jab jage tab savera hota hai. So you can always start and then you can judge whether, you know, how much, what level you are in. So start. Starting is important. All right. Okay, so most of the questions now are being repeated. You can go back to the video and listen to the answers. We will finish our exam analysis here, and we will be beginning with the recall. You already have the schedule of the recall there. The first recall is with our one of the favorite original gurus, Dr. Aishwarya Kaushik. He will be doing a recall of Cons Endo and dental materials. Just a quick introduction to Dr. Aishwarya. He is an alumnus of the prestigious Maulana Azad Institute of Dental Sciences. He has done his BDS and MDS from there with an All India rank of 5 when he has done his NEET PG. And he will be taking your recall for Cons Endo and dental materials. All right, I'll finish there. All the best to everybody. Don't be disheartened. Don't be too happy. Don't be too sad. Just take this exam neutrally. Learn from this exam and move on. All right. I'll see you all tomorrow morning with the oral surgery recall. Good night, everyone.
Good evening, friends. So, a sigh of relief after your INI exam today. Yes, obviously, all of us deserve some sense of relief and have a coffee or tea or whatever you like. Yes, as usual, as has been the previous 2 years' trends, the questions of endo cons were in abundance, right? Especially the part 1 paper. First of all, thank you, Dr. Himani, for introducing me. We have been colleagues in MAMC. Yes, she's also done her MDS from MAMC, and she's our academic head, motivating all of us. And well, guys, so today is the day, right? Endo paper, yes, I would consider it not easy, definitely not easy. Tough, yes. At the undergraduate level, of course, it's tough. Very clinical oriented questions. You don't do that level of dentistry in your internship. So no doubt the paper was tough. But a couple of things I'm very happy about. we at DBMCI have covered most of the questions that have come in the exam today. In both my live lectures as well as the recordings, obviously the coordinated notes that we give you, very good, strike rate that has come up, and I'm sure our DBMCI students will be extremely happy regarding that point. The other thing that gives me a lot of personal happiness and satisfaction is the textbook of endodontics that I wrote, which was published, the first print was published in 2020, and it is now that I see questions coming from there. So as you can see, this is my textbook of endodontics available with the online vendors at Amazon, Flipkart, etc., etc. And questions directly came from my book as well. Obviously, all those things I do incorporate in my lectures at DBMCI. So yeah, that is the thing that I can say I can pat my back as far as that aspect is concerned. So without wasting much time, guys, let us just do a quick diagnosis of the percentage of the questions. I'll be very precise here as far as endo was concerned. Endodontics specifically, this time many questions came from here. Then you had dental materials, which was a mix of repeat plus new questions, guys, and cons was towards the lesser side. Yes, that was the trend, but again, you cannot generalize it for the next 3 to 4 papers. It kind of keeps on rotating around a central axis, and that axis remains that endo cons DM is extremely important. That's the trend that we've seen both with INI and NEET in the previous at least 2 to 3 years. Yes, guys. So let's start with the question. Which of the following? First, tough question, guys. Which of the following is true? I've also done one very interesting thing today. Today only was the exam. We're doing the recall. Simultaneously, I'll be telling you about the topics as well, right? So that would just give you an impression of how important each and every, right across the spectrum, each and every topic is and how correlated they are. So first question, which of the following is true regarding hyperalgesia and allodynia? Now, this is one thing I'm personally very happy about. If our students who've read my notes, those people who've read my book, I always do, whenever I start endodontic diagnosis, I make it a point. If you see my notes also, I always take care of the pain pathway, isn't it? Start with what is happening with the A delta and C fibers, isn't it, guys? So when you see this hyperalgesia and allodynia, it's basically the triad. There is a triad of peripheral sensitization, guys. Peripheral sensitization, which consists of both hyperalgesia, allodynia, and what's the third thing? When I say triad, there has to be a third thing. What is that third thing? That's spontaneous pain, right? So basically, I'll just generalize it without making it too boring here. You have inflammatory mediators, prostaglandins, leukotrienes, in very high numbers in an inflamed tissue like the dental pulp suffering from irreversible pulpitis. So what happens is the threshold potential for the generation of the action potential, remember your physiology, right? Nerve muscle physiology, Genong, right? First year BDS, it reduces, right? So even at a low stimulus, it fires, the nerve fires. So what happens is an innocuous stimulus, like a simple, say, pat on the face, which is not painful, right, becomes painful, and that's allodynia. Now, that is where the examiner played a game, right? You had the fourth option as innocuous stimulus leading to a painful response, but that's only true for allodynia, guys. That's not a generalized term for peripheral sensitization, right? So this is only the answer for allodynia, not hyperalgesia, right? So what is happening is that in general, the action potential is being generated at a lower threshold firing potential, right? So therefore, the answer is increased sensitivity of nociceptive afferent nerve fiber, which is A delta and C fibers, and mostly C fibers, because the deeper is the damage, you're close to the pulp, and the pulp has got more of C fibers. A delta fibers are more of towards the periphery, isn't it? So the answer here, guys, would be increased sensitivity. And please realize this is increased sensitivity, which is basically leading to decreased threshold of action potential, right? So the answer is B, increased sensitivity of nociceptive afferent nerve fibers. Obviously, the options can be jumbled up, not necessarily in the order that they came in the exam, but I'm trying to be as precise as possible. Yes, guys, next question again, a very important question. And I lay a lot of stress on endodontic diagnosis when I teach it. So many of my GT questions are based on this concept, you know. So let's look at the question. It's a clinical question. What is the diagnosis? You have a mandibular first molar, okay? So it can be either this, it can be this, right? A mandibular first molar, right? Which is having lingering pain on a thermal stimulus. So he's not mentioning whether it's hot or cold stimulus. So it's a thermal stimulus, cold or hot, and there is lingering pain. Now, lingering pain means that it is going beyond a few seconds into few minutes and even hours, right? But there's no response to EPT. Okay, fine. So what? Whenever you have to diagnose a tooth as vital versus non-vital, you should do at least 2 tests, and the best are cold test and EPT. Now, EPT test is negative, but the cold test is positive. So, if I summarize my clinical diagnosis, it would be still a vital pulp. Please, I know many of you would have marked necrotic, right, with symptomatic apical periodontitis. That's not the answer. Yes. So TOP positive, that is one of the most important points of this question. It is TOP positive. The moment you see tenderness on percussion positive, the diagnosis is symptomatic apical periodontitis. It has to be. Yes. And the other hint that you get is it cannot be a chronic periapical abscess or a chronic apical periodontitis. That is a periapical granuloma. Why? Because usually they're chronic conditions. So they're more or less painless. Yes, they're bad, but they're more or less painless. Yes. No symptoms of periodontal disease. Periapical rarefaction is seen in relation to both the roots. So what does this mean, guys? You have this lower molar, you have these mesial and distal roots, and you have periapical rarefaction. Now again, you will say, sir, the tooth is vital, then how is there periapical rarefaction? So many times, my dear students, so many times in my GT questions, haven't I put this question wherein both in acute periapical abscess and symptomatic apical periodontitis, which can be secondary to irreversible pulpitis, where the tooth is still vital. Yes, you have the inflammatory mediator. The tooth is still vital. Yes, it's irreversibly inflamed. No doubt you have to do a pulpectomy. It's still vital. And you have the inflammatory mediators leaking out, coming out of the apical foramen and causing acute inflammation in the PDL. And that can manifest on the radiograph as probably no periapical pathology to PDL widening to some amount of periapical rarefaction. Yes, of course it can. Yes. So surrounding mucosa is normal. There is no draining sinus tract. That's a big hint that it is not a chronic periapical abscess, right? So chronic periapical abscess cannot be the answer. Symptomatic apical periodontitis in an irreversible pulpitis tooth. Wow, what a question. This is actually one of my favorite questions that I always make for my students in my GT papers. I'm so happy in that sense. That's an applied question. It is made from the theory of Cohen. And time and again, I've put this question for our students, or a similar question, right? Third, pulpal necrosis and symptomatic apical periodontitis is pretty close, but it's not pulpal necrosis, guys. If the examiner would have said that both cold test or the thermal test and the EPT both were negative, then I would have gone for a necrotic tooth, right? Condensing osteitis, again, not an option. Next question, yes, a tough one, guys. Real tough one question. This is from a couple of questions from Bleaching. Bleaching is very favorite of INI people. Small topic, but very favorite. And this is a new question, guys. So it's a brand new question here from Bleaching. All are true for bleaching of an endodontically treated tooth except. Now, the moment you see endodontically treated tooth, it's either you're doing a walking bleach from inside the pulp chamber or you're doing an external bleaching, just like you do for a vital tooth, isn't it? Chair side, 35 to 40% hydrogen peroxide, apply it, for 10 minutes, 2 to 3 times, and you get a nice result. Of course, you can do it both for vital and non-vital. However, when you see the options, you realize that the examiner is talking specifically about walking bleach because all the options are related to that. So let's look at the options. First option, etching of dentine in pulp chamber, etching of dentine of the pulp chamber, right, of the RCT treated tooth is done, right? Very good point, because this is a brand new point, right? You don't necessarily do it. You usually omit the small details when we are doing it, right? When we're studying it for prof exams, when we're doing other repeat PYQs. But as they say, God is in the details, right? Anyways, before I tell you the answer, other options, evaluation of obturation. Of course, you have to evaluate your obturation. If your obturation is not good, better not do working bleach. So we're talking of this endodontically treated tooth, guys. I'll take the color pink to show you that, you know, a nice obturation is done and you have to evaluate it, right? Third thing is, so that's obviously important, protective barrier is placed over root canal filling material or obturation filling material. Of course, a 2 mm thickness of GIC or preferably resin modified GIC should be placed before you place your sodium perborate mixed with distilled water, right? Otherwise, what happens is, what is the most common side effect of a walking bleach? That's cervical root resorption, right? Which will predispose the tooth to future root fractures. So you want to protect this so that it doesn't leak through the dentinal tubules. Yes, so that's right. Rubber dam isolation is done, of course. I mean, any restorative procedure, any endo procedure, you should do rubber dam isolation. Yes. Now, guys, even if you did not know the point A, rest 3 points are definitely right, right? So if I were in your, position, I would have definitely marked this. Even if I would have not known the correct answer precisely, but I would have answered it by exclusion. So answer A is right. Now I'll tell you why it is right. Etching of dentine and pulp chamber of RCT treated tooth is done. This is a false statement. That's what the examiner is asking. It is a false statement because you don't want to etch the dentine. What happens is that etching of the dentine again would really, remove all the smear layers from here, right? And again, there is a chance that, your sodium perborate would penetrate deep into the tubules and may leak onto the just apical to the CEJ, causing root resorption. Second, it has also been shown that if you don't etch the dentine, there is no significant decrease in the efficacy of bleaching, right? So there's no advantage and there is definitely a disadvantage. So you should not do it, right? Excellent. Next question, guys, again from discolorations. I'm also seeing the group. Any comments? I think wonderful. So I think all of us are understanding. That's why I don't have any comments. Wow, wonderful, guys. Wonderful. Yeah. All right, next question. Mother has had a history during gestation, that is during pregnancy, of being exposed to tetracycline, guys. All right. Tetracycline exposure is there of the mother during gestation, and the child obviously has discolored teeth. Now, what is true regarding the stains? So they are tetracycline stains, of course. Fine. Tetracycline stains, by the way, is a favorite topic of the INI people. They ask you how you manage them. This time they've asked you how do you classify them. So guys, this staining has taken place during the development of the tooth, right? Because the child was in the womb. During the development of the tooth, it has taken place. So obviously it's intrinsic, right? It's intrinsic stains. The other thing is, the examiner, just to confuse you, for the intrinsic stains, he's given you two options, whether it's endogenous or exogenous. It's endogenous, guys, because the mother has taken tetracycline, and tetracycline through the blood supply, crossed the placenta, has gone into the circulation of the child, of the baby. Yes, so this is endogenous. Intrinsic stain is the answer. And then you'll ask me, sir, then what is exogenous intrinsic stain? See, intrinsic stain is anything that's deep inside the tooth. So long-term tobacco use, like smokers, right? They would have intrinsic stains over a period of time, but that would be exogenous because that's taking place from the environment, right? From outside the oral cavity. And so that's what the answer is. Endogenous intrinsic stain is the best answer. Again, another option that can confuse you is congenital stains, but I would go with endogenous and intrinsic stain as the best answer, guys. Then, brand new question from cracked tooth syndrome, modified Iowa index. I'm sure our community dentistry ma'am will also be taking this, but since it's the answer is straight cracked tooth, and cracks and fractures is something that I deal with in detail in my lectures. So I would love to just quickly tell you, basically, guys, it's about, you have a cracked tooth, right? The patient has come with a cracked tooth. It's not an RCT treated tooth. Now it's a cracked tooth. The patient wants I don't want to get this extracted. So you do a root canal. So there is an index which gives you an idea of the prognosis or the probability of success. How long will the tooth be in service when it is cracked and the doctor has done a root canal treatment, right? So obviously, when the crack is, starting from the crown, yes, starting from the crown and going into the root, progressing into the root, the prognosis would be bad, yes. If associated with that, there is a periodontal probing depth, there is a pocket, and that depth is greater than 5 mm, then again, the prognosis is pretty bad. So I don't want you to go into the details of this, just have an idea that there's an index which helps you predict the prognosis or the survival probability of a cracked tooth, which is based on certain other factors, the extent of the crack, the associated periodontal defect due to bacterial contamination in the crack, which helps you to predict the life of the tooth, and that's the modified Iowa index, right, guys? Now, whether you need to go into the details and really, 5-year survivability, 10-year survivability, when the periodontal pocket depth is less, more, etc., etc. If I would have been in your situation, I would not have even attempted to memorize that. If that kind of a question comes, I mean, there are other important things to memorize, but at least know this. Yes, again, a brand new question, guys. Obviously, it's a tough one. I mean, we don't expect you to know this before, so yeah. Okay, guys, simple question, again, from cracks and fractures. Again, so see how many questions have come from cracks and fractures, right? So a patient complains of sudden pain on biting. That's it. The rest, the examiner is saying in the exam, in today's exam, the examiner is saying no other periodontal defect, no other endodontic defect, no caries. That's the provisional diagnosis that the doctor has made, is that of a cracked tooth. What else can he do to reach a definitive diagnosis? And this was a multiple correct answer type question in which you have options of OPG, CBCT, staining, and transillumination. Now, guys, OPG itself is even worse than a IOPA X-ray, right? So, I mean, why to go for OPG? But yes, CBCT can be done. Staining, of course, a dye, toluidine blue dye, right, can be put and you can see it under the microscope or loops. Then transillumination is another way of determining whether there is a crack that is there or not. So all these will help you reach a definitive diagnosis, and the option was BCD. All these three are correct. The various options were a permutation and combination in which they were incorporating OPG in a couple of options, and so the best answer was a combination of B, C, and D, guys, right? So this was a clinical question. This was I would consider this easy to moderate, right? Most of us should be attempting this correctly. This is the easiest question. J-shaped radiolucency, VRF, right? This is one of those questions in which you don't have to really think 5-6 times. Why I say 5-6 times? Even for the easiest of questions, I always recommend, my students know this, I always recommend read the question at least 3 times, rotate the concept in your head, then only mark it, right? So J-shaped radiolucency, halo radiolucency, step defect. J-shaped radiolucency, halo, step defect, right? RC treated tooth, that's another hint. A narrow, with a narrow opening. Periodontal pocket, flexible probe should be used. These are all features of VRF. VRF starts on the root usually, mostly in the buccolingual section. A crack is mostly in the mesiodistal section. These are all the possible MCQs that are asked here. Again, oh, wonderful. This is one of my favorite and also mentioned in my textbook, guys. What is the method of choice for pulp testing of a tooth with calcification? So pulp canal obliteration does not necessarily mean it's only the canal that's calcified. See, guys, when you read histology, dentine pulp complex is read together. So you are expecting not just calcification in the coronal pulp chamber, but also in the dentinal tubules, right? So if you have calcification in the dentinal tubules, guys, you apply hot, you apply cold, you apply air, you give sweet to the patient. I mean, that stimulus is not going to translate into any movement of the dentinal fluid because that's blocked with whitlockite and hydroxyapatite and whatnot crystals, right? Octacalcium phosphate and whitlockite, isn't it? That's a senior resident question. classic that's asked from Cohen, right? So the idea is to directly, I mean, to see whether it's vital or not vital, directly stimulate the A delta nerve fibers. How can you do that? With an EPT, right? So EPT is the best answer here. The other options were carbon dioxide, again, cold test, ethyl chloride, cold test, heat test. So A, B, C are thermal tests, not really good for premature calcification, which usually occurs following a traumatic dental injury, right? Cohen mentions this as premature sclerosis following a traumatic dental injury. Means the same, answer remains the same, EPT, right, guys? Again, a pat on my back here, I always tell this, even in the shortest TND videos that we record at DBMCI for traumatology, you always mention this, and I'm so happy that this question came. And as I said, it's written in my book also. So again, today was a day of immense satisfaction for me. Again, good question, guys. IBQ for Ellis and Davies classification. For this, I'll have to, commend, the examiners that they specifically did not, confuse the students with class 7, 8, a conceptual question. They showed fractures at 4 levels. At the undergraduate level, it's great to know all these 4 at least. So this was the first one, the root fracture, which is Ellis class 6. This was the answer. Obviously, the examiner had put an arrow over the pulp, the one which is crossing the pulp. So that's the answer was Ellis class 3. And then there was another line which was through dentine and through enamel. So those were Ellis class 2 and 1 respectively. The arrow was towards the Ellis class 3. So the answer was Ellis class 3. Pretty simple, and I hope most of us have done this correctly. Wow, good question, guys. According to IADT guidelines 2020, recommended splinting time for delayed reimplantation. Now, guys, where is this causing confusion? First of all, when you read Cohen, guys, and you read avulsion, they say 1 to 2 weeks. And the examiner was so smart that even if you had read Cohen, he had given 1 week as one option, 2 weeks as another option. So you had to go with IADT. And I tell you, INI people, they always, for traumatology, their data always refers to IADT. So if there is any confusion between Cohen, Ingle, between mainly Cohen, Ingle does not have a chapter of traumatology, but Cohen, there's a confusion between Cohen and IADT, go with IADT. And that remains true for NEET also. So guys, in general, the IADT guidelines tell you that the avulsion splinting is flexible splinting done for 2 weeks. It's only in a situation of associated alveolar bone fracture or jaw fracture where you would do slightly more rigid splinting, slightly more rigid, not rigid, slightly more rigid for 4 weeks. But that's the only situation. And sometimes the universal answer is 2 weeks. So whether you have, whether the patient has come after 60 minutes or within 15 to 20 minutes or between 20 minutes and 60 minutes, all the 3 situations, always go for the first and foremost emergency treatment is just put the tooth back in the correct position, verify with the X-ray, do a flexible splint. Recall the patient after 2 weeks, right? So between 1 and 2 weeks, 2 weeks is a better answer simply because it's given in IADT guideline. Yes. Second, delayed reimplantation, no difference, 2 weeks. Only one situation, sometimes what happens is there's too many heavy occlusal contact. So it's only after 2 weeks when you're removing the splint that you can take the decision of just extending the splinting time by about 1 week. That's an added point. Even if you forget it, doesn't matter, right? So guys, 2 weeks is the answer. There is no doubt about this. Yes? Excellent. Wonderful. First detectable, oh wow. Now this is not a good question, man. First detectable biomarker in dentinal fluid in case of irreversible pulpitis. And I tell you what, the answer is actually MMP9, but unfortunately or fortunately, this was not given in the options. So the options were calcitonin gene-related peptide, IL-8 and substance P, beta defensin 2 and TNF alpha. Now, after MMP9, the best answer would be IL-8 and TNF alpha. Now, the controversy remains that what do you mark? Do you mark IL-8 and substance P option, or you mark TNF-alpha? That's anybody's guess. This is most probably from some the examiner who would have made this question must have done a thesis based on this, or some recent article from this. If I were you, when I saw the data, I mean, as I said, it's anybody's guess. IL-8, TNF-alpha, both are equally important after MMP9. If MMP9 was in the options, that was the best answer. Second best, according to me, would be IL-8, guys. Okay, but yeah, if this answer in future, in the next 15, 20 days, 1 month changes, I will definitely update this with you guys, right? So as of now, IL-8 is the best answer. All right. Oh, wow. Next question is again from vital pulp therapy. Applied question. Again, just like traumatology, the favorite of INI people, right? Vital pulp therapy is one of the favorite topics of INI people. Time after which bleeding stops in the vital pulp tissue after application of 2.5% sodium hypochlorite serves as a surrogate marker for. So let's just understand the concept here. Basically, what he's saying is that the recent or the most recent protocol, not the protocol actually, but the data says that even if you have like severe pain, even if the patient says, I have lingering pain, and mind you, this is not what you're supposed to follow clinically as of now. This is all being done at an institutional level, not at a private practice level or the undergraduate level. So what they say is that, I mean, to know the level of pulpal inflammation, you should put sodium hypochlorite dipped cotton pellet, yes, on the pulp stump up to 10 minutes. Now, up to 10 minutes is in Cohen, up to 15 minutes is in Ingle. And if the bleeding stops, then the pulp underlying that, at that level, right, at that level, is reversibly inflamed or normal. So you can protect it. But if the bleeding doesn't stop even after 10 to 15 minutes, you'll have to again take out some more pulp, right? Take your round burr at high speed, take out some more pulp, and then again repeat this procedure. So you will ultimately, by doing this sequentially, you would ultimately know whether you're going for a full pulpotomy or a partial pulpotomy or a pulpectomy. Yes. So what is this? What is this telling you about? It is telling us about the depth of pulpal inflammation. Simple. Yes. So that's the best answer here. Depth of pulpal inflammation. Even if you guys have gone wrong or left this, I understand this is more of MDS level, isn't it? But depth of pulpal inflammation is the answer, guys. Depth of pulpal inflammation is the answer. Next question, guys, is basically talking about what is it talking about, guys? It's talking about basically IPC. So question is incomplete caries removal in a deep carious lesion in which the tooth is asymptomatic or it is showing symptoms of reversible pulpitis. So basically he's telling you about the thing that all our teachers tell us from third year onwards: remove the infected dentine, let the affected dentine, which can be remineralized, stay behind. Why do you want that? So that you can do an IPC. Why do you want that? You can preserve the tooth structure, which can be remineralized, and you don't go too deep and damage the pulp. So that's the answer. So the answer is protect dental tissues and prevent further damage to the pulp. Wonderful question, in the sense that if you would have taken a deep breath, it's an applied question, but if you would have taken a deep breath, thought in your head, okay, fine, basically what he's talking about, the broader topic is VPT, vital pulp therapy, and specifically he's talking about IPC. Yes. And the answer is the aim and objective of an IPC: to protect the dental tissues and prevent further damage to the pulp. Yes, that's the simple, logical, clinical based answer, guys. Yes, guys. Yeah. So in that sense, a wonderful paper, right? Isn't it? The new questions were there, but yes, not that fewer questions were. You could solve them, even if they were not PYQs. If you had your concept strong, you could solve them. Next question is a tough one, guys. I understand. Composites, not true about heated composites. So basically he's talking about at the undergraduate level, we don't really read much about heated composites. So heated composite is nothing but, you're taking a block of composite, heating it to about 60 degrees Celsius. That's about 140 degrees Fahrenheit. Why do you want to do that? You generate more mobility, molecular mobility in the monomers, the methyl bis-gamma and U-DAMA monomers, so that the degree of conversion is more. You cure it in lesser time, you will cure it, and the degree of conversion is more. So when the degree of conversion is more, that means your carbon-carbon double bonds, more monomers are getting incorporated in the polymer chain. So if your degree of conversion is more, then your strength properties, your fracture toughness is better. Yes. Also, the material becomes, even a packable composite becomes slightly flowable. So better marginal adaptation to the walls. Yes. The only problem is that the polymerization shrinkage stress will be more. Why? Because, guys, the curing time is less here. The curing time is less because the molecules are moving much faster amongst themselves. They find each other faster. So they cross-link and enter into addition polymerization faster. So when that happens, the curing time is less, but the shrinkage stresses that get incorporated do not get the time to stress relax. And therefore they get incorporated. So what all is not true? So we'll have to see what all is true. Shows more shrinkage stress than unheated composites. Yes. Shows reduced curing time. Yes. Shows better polymerization, greater curing, greater degree of conversion. Yes. If there was an option which was saying better hardness, better surface hardness, etc., better fatigue strength, etc., that would also have been right. There is an option which says, guys, that should be cooled to room temperature before inserting in the cavity prep. No, that should not be done. Otherwise, the entire advantage of making a packable composite slightly flowable is lost. So you have to immediately put it inside the cavity prep, guys. So that's a wrong option. And that's the answer. So not true. He's asked, not true about heated composites is that it should be cooled to room temperature before inserting in the mouth. That's wrong. It should not be cooled. Yes, guys. Wonderful. Oh, wow. This was a new question. I do not expect anybody to know this. Which of the following is true for decreased flux intensity on increase in temperature? So what this guy is asking is, guys, that I was just seeing the comments here. Where are my students? Where are our students, guys? You watching this, or you all have gone out to party? Anyways, which of the following is true for decreased flux intensity on increase in temperature? So if you see the options, he's basically talking about magnets. So before we see the options, guys, basically he's talking about there are different materials which form magnets, like neodymium. You have neodymium magnets, and you have samarium. That was the two types of magnets asked in the exam. Samarium cobalt magnets. So you have neodymium magnets and you have samarium cobalt magnets, right? Now, what happens with these magnets is that there is a temperature at which the magnetic property is lost, and that temperature is known as Curie temperature. All right. So when the magnetic property is lost, that basically means there is a decrease in flux intensity, right? Because the element, the constituents become more mobile and they are more in a random configuration, right? So now neodymium's Curie temperature is pretty low, like 300 degrees Celsius. Yes. And samarium cobalt's Curie temperature is pretty high. That's about 700 degrees Celsius. So if you know this, which of course you won't be knowing because this is something that is a brand new question taken from some recent article, and obviously this is a question that is basically made so that you don't answer it and don't get a negative mark, right? But obviously since it has come now, we have to discuss it because now it becomes a PYQ, right? So guys, which of the following is true for decreased flux intensity on increase in temperature? So obviously between neodymium and samarium cobalt, neodymium has got a very low Curie temperature. So neodymium magnet with a low Curie temperature will show a significant decrease in flux intensity on increasing the temperature. So let's look at that option. Neodymium magnet with increased Curie temperature, no. Neodymium magnet with decreased curing temperature, yes. Samarium cobalt magnet with increased curing temperature, that's a true statement, but that's not the answer. Because as compared to neodymium magnet, it does not show a decreased flux intensity. Samarium cobalt magnet with decreased curing temperature, that statement itself is false, so cannot be the answer. Right, guys? So option B is the answer. Yes? Yes, guys? All right, next question. Which of the following represents weak attractive intermolecular forces secondary bond? Now, this is from the chapter of physical and mechanical properties. Guys, you learn about what? Ionic bond. That's a strong chemical bond. You learn about covalent bond, strong chemical bond. Then you learn about these secondary bonds, which are basically hydrogen bonds and van der Waals forces, right? So these are weak secondary bonds, attractive bonds, right? And then there is an option of metallic bonding. Now, what is metallic bonds? Metallic bonds is the pure metal which is present in a crystal structure like FCC, BCC structure, right? So what happens is that the valence electrons are delocalized. So if you have this metal, the electrons surrounding it, they kind of get delocalized in the local area to form a sea of electrons. So what happens is that if I have a metal which is say in body-centered cubic structure, yes, so at the edges you have these 8, and then there is a big element here, atom here, right? So all these would be present as positively charged ions, and there would be a sea of electrons surrounding it. So that's metallic bonding, right? Yes. So let's look at the options. Which of the following represents weak attractive intermolecular forces or secondary bond? Loss of valence electrons, that is not the answer because that is an ionic bond. Sharing of valence electrons, that's a covalent bond. Hydrogen bonding, yes, that's the answer because that's a secondary bond. Yes. And depolarization of valence electrons in a local common sea is basically representative of metallic bonding. Yes. So the answer is hydrogen bonding. Is that right, guys? The answer is hydrogen bonding. Yes? Yes? Wonderful. So new question, tough one. Oh, good question, guys. Basic crystal structure common to titanium, zirconium, and zinc. Now I'll tell you what. I don't expect you to know this question directly, but you can reach the answer. Why? In all my classes, whenever I teach you about titanium, whenever I talk about casting or welding or brazing or soldering, I always tell you, and even in wrought alloys, always tell you that titanium exists as hexagonal close packed. Yes, that's the alpha form. And at 883 degrees Celsius, it changes to the beta form, which is body-centered cubic. Now, there's no doubt about that. Titanium, if you know 100% that at room temperature or at any temperature less than 883 degrees Celsius, the basic structure of titanium is hexagonal closed packed. And one of the metals here is titanium. And the hexagonal closed packed is the answer. So if I were you, I would have marked, even if I would have not known the direct answer, I'm going to go with hexagonal closed packed, guys. Even if you don't know the starting structure of zinc or zirconia. And please don't get confused by the fact that, you read zirconia as tetragonal to monoclinic. That's a separate thing. That's zirconia. That's not zirconium element, all right? So you have to apply slightly some application here and a new question, and you can definitely get this correct, guys. Yes? So hexagonal close packed is the answer. Yes, guys? Wow, what a question. Next question. Now, this is a modified question of a PYQ. Similar question was asked last year in November 2024 INI, but this is modified and it has been made tougher. I'll tell you how. The question is primary technical reason. The topic is dental polymers. The primary technical reason for doing bench curing or bench setting, right? For doing bench curing or bench setting of heat cure acrylic resin is what? So basically, guys, what he's talking about is you've done your dewaxing, you're making your denture, you've done your teeth setting, you've done your dewaxing. Now it's the time to pack it, right? So you mix your powder liquid in 3:1 ratio, right? You make a dough form and you make a horseshoe type shape. pack it and flask it, right? Tighten the flask. Now, immediately you don't put it in a water bath. You let it bench set or bench cure. Now, this is not bench cooling. This is bench curing. Please understand, this is bench curing or bench setting. Now, there are a couple of reasons why you do it. The first and foremost and most important is that, guys, you mix that powder liquid and you're packing that heat cure in the dough stage in a very constricted space, which is occupied by your removed wax and your denture, cold cure denture base, isn't it? Only your teeth are there on the opposite side, right? That's a very constrained, small, narrow space. And then you're going to further tighten it, by rotating the flask clockwise. Yes. Now you need some time for the pressure to distribute uniformly so that you get a nice uniform thickness and no distortion or warpage takes place. Yeah, right? So you want the pressure, when you apply the pressure on packing, you want it to dissipate uniformly for some time. And then only put it in the water bath, right? To heat cure it. So that is the most important point. Second most important point is good enough monomer diffusion so that it reaches, again, uniformly to all the teeth and ensures good chemical bond with the acrylic teeth and the denture base. Both are correct. And both were there in the options, which is a better answer. Prevention of non-uniform distribution of stress or pressure. So guys, two options were there which were right. See the examiner, how smart he is. So so first option was prevention of non-uniform pressure distribution in the dough stage following packing. The second option was adequate diffusion of monomers in the denture base so that a strong chemical bond can be formed between the resin and acrylic teeth. Both are right. But better answer, guys, is the option A, prevention of non-uniform distribution in the dough stage. As a single best answer. Obviously, options C and D are wrong. Loss of monomers by evaporation is wrong. Cooling after curing is basically bench cooling. That's not bench setting, right? Yes, guys? Wonderful. Oh, next question. Again, controversial one, guys. Which of the following causes inaccuracy in electronic apex locator measurement? Which of the following causes inaccuracy in electronic apex locator measurement? Yes. Now, guys, necrosis obviously is not the option. Modern day apex locators don't really, it doesn't really matter whether you're dealing with vital, non-vital tooth. Periapical radiolucency also cannot be the answer. Now, there is a problem with open apex. Yes. Usually, as they say, paper point method is the best method for open apex cases. Here, the examiner gave you a twist. He said non-blunderbuss open apex case. So basically what he's saying is that it's an open apex case, but it's not that bad a situation, right? So it's not like this. So this is the tooth, right? So that's the blunderbuss, diverging canals, very diverging walls, very thin walls. And again, it's an open apex case. What the examiner is saying is, now this is a blunderbuss, right? Now this is a non-blunderbuss. It's not diverging. It's converging, but yes, it's still an open apex. Now, ideally, in this situation also, there can be a problem with the apex locator. But there's another option which says presence of a separated instrument in the canal. Now, guys, if there's a separated instrument in the canal, basically it's like an obstruction, right? So the file won't go to the apical constriction. If it's not going to the apical constriction, it will not give you a right reading. So I think both options are correct, but I feel that the better option is presence of separated instrument in the canal, right? If your file is not, see, if there's another problem, if the fractured instrument is such that part of it is protruding out of the, part of the fractured instrument is such that it's in the apical third and part of it is in the periodontal ligament. Then also when your K file, which you are using to check the working length, and you attach your apex locator, then also it's going to close the circuit, and at a very short length, the circuit will be closed, right? Will be completed, and it will give you a false result. Second situation is that even if the file is well within the confines of the canal, if you're not able to bypass it, then also it's going to give you it will not give you a good reading. So I think both are correct, but a better option would be, in this case, presence of separated instrument in the canal, guys. Right? But yes, this remains controversial as of today. Better option, according to me, is presence of separated instrument in the canal. Very commonsensical. I don't want to overthink here. Commonsensical. Next question is a simple question, guys. Syringe and needle is the most common method of irrigation. Yes. Which of the following is not true regarding it? Now, guys, 30 gauge side vented closed ended needle should be used, of course. Use of luer lock is mandatory. Again, obviously, you don't want your needle to fall in the pulp chamber. A small volume syringe like 2.5 ml syringe is better for handling and better tactile sense, of course. You don't want to use a 20 ml, 50 ml syringe in a small tooth, right? You're not operating on the leg, you're operating on the tooth, right? The option which is not correct and which is the answer is that syringe and needle irrigation guarantees the flow of irrigant in all areas of the canal. Now that's a false statement, guys. It doesn't guarantee. It does not guarantee, guys. Yes, that's a big challenge with syringe and needle irrigation. That's why you do all those things, right? Manual dynamic irrigation, use of ultrasonics, sonics, endo activator, this and that, negative apical pressure, right? Next question, again, I'm very happy. I always do this. It's there in my book also, notes also, lectures. What is responsible for the tissue dissolving property of sodium hypochlorite? Hypochlorous acid, guys, HOCl. Yes, HOCl is the active, what is the active agent of sodium hypochlorite? OCl ions, right? Which are basically from HOCl, right? Dissociates into proton and OCl ions. Yes. Internal transportation is a ledge, guys, simple. So you have a canal with a curve and you are, filing it and you're not pre-curving it, or you're using a big file, large sized file, and you're creating a platform here on the outer curvature and causing internal transportation of the canal. External would be a zip, apical zip. Internal would be a ledge, right? Match the following. This is from the topic of obturation. Pretty simple, guys. Single cone obturation, what do? You take a night eye instrument, 3006 GP. Simple. Coat it with sealer, obturate. That's what you do in the pro taper technique, isn't it? Lateral compaction is a cold obturation technique. Warm vertical compaction, you get a nice thermoplasticized apical seal. Yes. And Gatta core is one of those carrier-based obturations in which you use a plastic carrier coated with alpha phase Gatta parcha. So actually in the exam, it was pretty simple. They were all, they were all corresponding. They were all horizontally corresponding with the right answer, right? Steps of warm vertical compaction. Simple. You do cleaning and shaping, then you coat the canal with sealer. Then what do? You make a apical plug of 5 mm Gatta parcha, right? Thermoplasticize it and then do backfill. Pretty simple. So cleaning and shaping, sealer placement, down pack. Down pack is basically creating that 5 mm plug of Gatta parcha, the apical third, and backfilling the rest of the middle third and coronal third of the canal. Yes. So pretty simple, but yes, clinical based question. Patient reports with severe pain 24 hours after obturation. What cannot be the reason? Now, guys, immediately, that's almost immediately. So you can have a high occlusal contact, yes. Periapical extrusion of debris, basically flare up, yes. Over obturation, again, there can be pain. Coronal leakage. Now, coronal leakage, because of coronal leakage, it will take some time, guys, a few months for the RCT to fail. So that is not the reason. Again, clinical question, pretty simple. I would consider it moderate, not very tough. You should answer this. Next question, which crown will cause least wear of opposing natural enamel? Now, this is from dental ceramics. So the options were monolithic zirconia, highly glazed zirconia. Zirconia is not good for the opposite tooth, guys. It causes pretty high wear. Lithium disilicate also better than zirconia, but it also causes wear. Ultra low fusing ceramic, pretty soft on the opposing dentition, so that's the answer. So ultra low fusing ceramic, which is fusing at a temperature of less than 850 degrees Celsius. Again, I'm very happy. I always do this table of classification of ceramics into ultra low, low, medium, and high, isn't it? Our students will recall, isn't it? Which is not a technique of CAD CAM. This is a repeat question as it is, guys. So the answer is pressing, right? Ideally, the question should be, which is not a technique of 3D printing. because selective laser sintering, stereolithography, press and fluid deposition modeling are actually 3D techniques. But the answer here is pressing. You will have to, in such a situation, you will have to tell yourself that here there is a misprint. All right. The answer remains the same. That's pressing. Not a feature of CAMBRA. Now, CAMBRA is what, guys? Caries management by risk assessment. I know our community dentistry ma'am will take this, but just because it's like overlapping with cariology, just a quick discussion. Risk assessment is there. Yes, whether the patient is taking a lot of Coca-Cola. Preventive factors, yes, whether the patient is brushing his teeth twice daily, flossing, fluoride, etc. And risk stratification. You would classify the patient based on this, based on the caries risk assessment and preventive factors. You are going to classify the case as low caries risk, moderate, high, or very high, right? So what is not done in CAMBRA is caries assessment. You are not dealing with whether the caries is deep, very deep, moderately deep, shallow, etc. So that's the answer. Not a feature of CAMBRA is caries assessment. Yes. Thickness of MTA plug, guys. This is a repeat. This is 3 to 5 mm. Thickness of MTA plug in apexification. The complete question was thickness of MTA plug in apexification. Answer is 3 to 5 mm, guys. Simple. Air powder abrasion, repeat. Air powder abrasion is sodium bicarbonate. Again, I'm not very happy with how the examiner mentions air powder abrasion. It's actually air abrasive polishing, right? If you see the original Phillips, it's air abrasive polishing or air abrasive polishing or air polishing. Air abrasive polishing or air polishing. That's a better term. But anyways, the answer is sodium bicarbonate. Okay, temperature sensitivity of dental pulp is due to which of the following nerve fibers? Guys, it's not C, it's A delta. If you see the dentinal hypersensitivity master diagram in my notes at DBMCI, in my textbook, in my lectures, we always do this. Just open your notes and you will see, guys, a simple diagram which tells you what? Which tells you the dentinal tubule, and you have various stimuli: hot, cold, osmotic, and dehydration, right? So hot, cold, temperature. What is it affecting? A delta. Obviously, if the injury is deep, C fibers are exposed, pulp is exposed, that will also respond to hot and cold. But in general, temperature sensitivity out of A delta and C, A delta is the right answer. Yes. So A delta is the right answer. Yes. Statement A, again from Obturation, plugger in cold lateral compaction should be placed within 2 mm of the working length. Now this statement A is actually a PYQ. Last year the question came in which they were asking you to what depth, which is correct regarding the depth of the plugger. And the answer was 1 to 2 mm. Here they have modified it. Now here they're saying plugger in cold lateral compaction should be placed within 1 to 2 mm of the working length. That's right. That's a true statement. Second statement is hand spreader. It's actually spreader. Spreader, not plugger. Spreader in cold lateral compaction should be placed within 1 to 2 mm of the working length. Second statement is hand spreader produces less stress on the root than finger spreader. No, guys. Hand spreader has got a proper handle, right? Finger spreader is like a file. So hand spreader creates more hydraulic forces. Yes, there is more control, but it causes more forces and it predisposes the root to fracture more than a finger spreader. So statement B is false, right? So statement A is, answer is statement A is correct, B is false. Yes, guys, statement A is correct, B is false. So good clinical question, modification of a PYQ. Okay, simple question, guys. External cervical resorption is differentiated from internal resorption. The best answer out of all the options, there are multiple ways, but the best answer is tube shift, parallax X-ray. I mean, an internal resorption will not, it's like वो canal से चिपक गया, right? It's like it's a ballooning or dilatation in the canal. So whatever horizontal angulation you're shifting the tube, the lesion will stay continuous with the canal outline, right? But when you shift the tube, the cervical resorption will will also shift. Slob rule, right? Same lingual, opposite buccal. So if I'm shifting the tube, mesially, and same lingual and opposite, it would shift opposite when I shift the tube buccally. Right, guys? So the answer would be in the parallax radiograph, the ECR lesion moves with the tube shift, whereas internal resorption stays centered in the canal. That's the best answer, guys. Right? So the moment you see this option, that becomes a better answer than other options. Right? In a trauma case, a simple question. Trauma case, the tooth is mobile but not dislocated. The answer is subluxation, guys. That's the definition of subluxation, right? According to the law of symmetry, now Krasner and Rankau laws always do this. I always do this in my live classes. According to the law of symmetry, the law of equidistance is applicable to all of the following except the maxillary molars. That's the simplest question. Yes. So you have the law of symmetry is in a lower molar, that's the pulp chamber. The line drawn through the center mesiodistally. The mesiobuccal, mesiolingual, distobuccal, distolingual canals are equidistant and perpendicular. That's the first and second law of symmetry, right? But this is not applicable for maxillary molars. Yes, that was the question. So maxillary molars is the answer, simple. After 1 year, next question, guys, clinical. After 1 year, root canal failed. The diagnosis was a missed MP2 canal. Obviously, you will redo non-surgically. So retreatment without any surgery. So that's the answer, guys. Other options were, and put them on antibiotics and analgesics or do apicectomy or extract the tooth. No. Redo treatment, non-surgical. Okay, now this is a tough one, guys. Slot in the titanium trauma splint is of which shape? So guys, if you see, read your Cohen, there is the titanium trauma splint, by the way, is one of the ways of doing flexible splinting in avulsion case or even in other cases. You can do it for whatever, subluxation, lateral luxation. Now this is of titanium. It's not available in India, and it's like a thick mesh in which there is these rhomboid shaped slots in which composite will be placed for bonding. So the answer would be rhomboid, right? So this is obviously, I don't expect you to know this. The answer is rhomboid, guys. Yes. Dental stone and model plaster are which type of gypsum products, guys? So stone is impression plaster is 1, model plaster is 2, stone is 3, stone high strength is 4, and high strength high expansion is 5, right? So he's asking stone and model plaster, right? So it's 3 and 2. So please, in such questions, the examiner is trying to confuse you. One option was 2 and 3, and the other option was 3 and 2. So the answer is 3 and 2, guys. Yes, stone and plaster, model plaster. So answer is 3 and 2. Wow, what a long endo cons DM, right? So guys, that was the paper. As I said, I'm slightly disappointed with some of the questions. I mean, some of the questions were made for you not to answer. 2-3 questions, very tough, right? But yes, some of the questions were there which were not direct application based. As I said before the exam, take a deep breath, stay relaxed. You could answer them. For a few things, I'm very happy. Most of the questions came from my discussion, what we do at DBMCI, and some applied tough questions came from my textbook also. So for that, I pat my back, and I wish you all the very best. And I think our medicine sir, Dr. Rajesh Kubba sir is there. So he'll take it from here. And I think Abhirami ma'am will also be there for physiology. So guys, all the very best. And keep studying hard today. 1 or 2 days, just relax. And keep studying hard, keep the faith, keep taking your God's name. And best wishes to you. Thank you, guys.
All right, so a very good evening, everyone. I hope everyone has done the exam well. So now I'll be discussing the medicine questions. So majority of the questions are those which are present in my videos, which are there on the DBMCI MDS app. So there are totally 4 questions which have come up, like one is from the respiratory system, one is from the, the critical care, that is the anaphylactic shock and all. And the other question is from the blood transfusion, and the other from the respiratory system about the tuberculosis. So let me discuss all these questions now. Right. So, this was the first question. So, which of these protocols need to be followed for routine dental procedure in a patient who is recently diagnosed with tuberculosis? Right. The first option is, like, the first point is 3 consecutive negative sputum smears, clinical improvement in the symptoms, at least 2 weeks of anti-tubercular therapy with proper regularity and compliance, and fourth is completion of anti-tubercular drug therapy. So now the question is, like, among these 4 points, 1, 2, 3, 4 points, like, which is the one which has to be followed in a recently diagnosed tuberculosis patient for following a routine dental procedure? The first point is correct. That is 3 consecutive negative sputum smears are, yes, that is one of the part of the routine dental procedure that need to be followed. Clinical improvement in the symptomatology, that will tell us what are the symptomatologies that has to be reduced. Cough has to be reduced, the fever has to be reduced. So if that is being reduced, the cough and fever is being reduced, that we call it as the clinical improvement in the symptoms. So whenever there is clinical improvement of the symptoms, that is very good. Right. So that is considered to be one of the routine dental procedure in a patient. And the third one is at least 2 weeks of anti-tubercular therapy with proper regularity and compliance. That is also the part of the routine dental procedure. Whereas completion of anti-tubercular therapy, see, for the completion of anti-tubercular therapy, it takes almost 6 months. So it is not mandatory, or it is not required that you need to wait for 6 months to go ahead with the dental procedure. So your point number 4 is incorrect. So what is considered to be correct now? That is your 1, 2, and 3. 3 consecutive negative sputum smears, clinical improvement in the symptoms, at least 2 weeks of anti-tubercular therapy with proper regularity and as well as compliance. These 3 points are correct, right? Then, okay. Right, next one is, right, so we have procedure going on in the dental office. And after oxygen therapy, which is the next most useful drug for conditions like severe anaphylactic reaction, acute asthma resistant to albuterol therapy, or even resuscitation of patient after the cardiac arrest? The options are amiodarone, epinephrine, midazolam, then nitroglycerin spray. So what you have to remember here, in a case of severe anaphylactic reaction, what is the drug of choice? The drug of choice is the epinephrine, right? And this particular epinephrine we give subcutaneously, that will reverse this anaphylactic reaction. And what this epinephrine will do, this particular epinephrine will cause intense bronchodilation, and thereby that acute asthmatic attack will get reverted with the epinephrine. So the answer here is B, that is epinephrine has to be given for the severe anaphylactic reaction. Then, yes, so this was one of the slightly tricky question. Right. So we have a patient like almost had 700 ml of the post-operative blood loss after the resection of a tumor. Which of these is incorrect regarding the same? Right? Which of this is regarding incorrect regarding the same? First point, adequate post-operative analgesia will bring blood pressure to normal and pulse rate to less than 100 beats per minute. So this is a correct statement. Why it is considered as correct? Because adequate post-operative analgesia, what it will do, first point, it will bring the blood pressure and as well as pulse to normal. Why? Because that will reduce the pain, and that will reduce the heart rate, and that will also reduce the blood pressure. So that will make the vitals to be normal. That is very much required. Next, now 700 ml blood loss. This is classified as the class 1 hemorrhage. Yes, see, 700 ml blood loss, it is less than 15% of the total blood volume that is being lost, and that is considered as, right, that is considered as the class 1 hemorrhage. Then followed by that, and so this, your point number B is also correct. Then urine output more than 30 ml per hour. See, the class 1 hemorrhage, it preserves the renal perfusion, right? So when it is preserving the renal perfusion, the urine output will be more than 30 ml per hour. That is also the correct statement, right? And the next one is post-operative whole blood transfusion is must. See, it is a post-operative blood loss. In case of post-operative blood loss, the whole blood transfusion is not needed, right? Whole blood transfusion is not needed in post-operative blood loss. In case of that too a class 1 hemorrhage, what is adequate or what is sufficient? The crystalloids are adequate in case of the class 1 hemorrhage, right? So the answer to this particular question is, that is your D, post-operative whole blood transfusion is must. In class 1 hemorrhage, you don't require the whole blood transfusion, right? Whereas your A, B, C, they are correct. Then the last question in the medicine, a patient is presented after trauma to the emergency department with hyperresonant chest on percussion. There is absence of breath sounds or mobility on one side of the chest, and there is also a tracheal shift. What is the diagnosis? See, the very important point, the hyperresonant chest on percussion. There are only two conditions where you will have hyperresonant chest on percussion. One is pneumothorax. This is one condition. And the other condition where you can have the hyperresonant note is, that is in COPD patients, that is emphysema. These are the only two conditions where you will have the hyperresonant chest on the percussion. That is fine. Now, so the answer is what? A. Then how will you rule out the other options? So the second option, you take cardiac tamponade. In case of cardiac tamponade, you will not have absent breath sounds, but what is that you will have in case of the cardiac tamponade is the muffled heart sounds will be there in case of the cardiac tamponade. And you don't have the hyperresonant note in case of the cardiac tamponade. So option B is ruled out. Next, you take massive hemothorax. In case of massive hemothorax, you will have a dull note on the percussion. You will not have the hyperresonant note, you will have a dull note. But in case of massive hemothorax, do you have a tracheal shift? Yes, tracheal shift will be there. But what is that which is ruling out your massive hemothorax? That is hyperresonant note on percussion is ruling out your massive hemothorax. Next is your pyothorax. Even in case, what is this pyothorax? Pyothorax is that where you have excess amount of pus in the pleural space is what is called as pyothorax. In case of your pyothorax, yes, there will be absent breath sounds or muffled, decreased breath sounds will be there. In case of pyothorax, it will not completely absent. Decreased breath sounds will be there in pyothorax. And you will have a dull note on percussion. You will not have the hyperresonant note on percussion, right? And in case of the pyothorax, what is that you will have? You will have a tracheal shift. But what is the point which is going against your pyothorax? That is hyperresonant note chest on hyperresonant chest on percussion is not the part of your pyothorax. So what is the answer in this particular question now? The answer in this question is, that is the tension pneumothorax. Okay. So these are the 5 questions. Very simple question. The only slightly difficult one was this particular third question, right? And except for this, the remaining are all directly from my notes and from my videos on the DBMCI MDS app, right? So with this, I'll just wind up this medicinal questions recall. Then I'll just hand over this particular session to Abhirami ma'am, where she'll be discussing about the physiology questions. Thank you.
Thank you, sir. Very good evening to all. So welcome to this INICET MDS recall session, physiology questions, with me, Dr. Abhirami, your physiology faculty. With regards to physiology, there were around 2 basic questions in physiology, one from thermal regulation and the other one from GIT physiology. Very simple, basic concepts only. So let me move on to the first question. The first question was on thermal regulation. Thermal regulation itself is a very, very important topic for NEET MDS as well as INICET MDS, because repeatedly we are seeing questions, physiological basis of thermal regulation. So the first question was about increased body temperature will lead to. So let's understand that when your body temperature increases, what is the change that will happen inside your body in response to an increase in body temperature? It means already in your body, more heat is produced. So what will be the other response that happens following this? Let's split each of these options. The first one option was thermogenesis. What is thermogenesis? The word thermogenesis itself, thermo means temperature. Genesis means production. So thermogenesis means heat production, the mechanism of heat production inside the body. This is called thermogenesis. And thermogenesis will obviously increase your body temperature. If there is more heat produced in the body, there's increase in body temperature. The second option, inhibition of neuron of sympathetic chain of posterior hypothalamus. What is the role of posterior hypothalamus in thermal regulation? Posterior hypothalamus. Do you remember this? We had learned this in our classes. We remembered hypothalamus like a car and we learned this. Yes, if you compare hypothalamus to a car, in a car, anteriorly, what do you have anteriorly in a car? We have AC, and this AC produces cooling effect on the body. So anterior hypothalamus, imagine hypothalamus like a car, anteriorly hypothalamus, this causes cooling effect on the body. Posteriorly, in a car, posteriorly, backside, what do you have posteriorly? Silencer. Silencer produces heat. So posteriorly, the posterior hypothalamus, this has heating effect on the body. It produces heat. So anterior hypothalamus cooling and posterior hypothalamus is by heating. How does posterior hypothalamus produce heating? How do you produce heat inside the body? By shivering. Posterior hypothalamus has this shivering mechanism. Whenever you shiver, all muscles are contracting. When all muscles are contracting, more heat is produced. So shivering is a mechanism of heat production by the posterior hypothalamus. So inhibition of neuron of sympathetic chain of posterior hypothalamus. So the question is, if posterior hypothalamus is inhibited, what is the effect if posterior hypothalamus is activated? Heating effect on the body. There is more heat produced in the body. So if you inhibit the posterior hypothalamus, yes, just the opposite. This would decrease the body temperature. This would decrease the body temperature. Look at option C. Activation of posterior hypothalamus, dorsal medial nucleus of posterior hypothalamus. What will happen if you activate your posterior hypothalamus? There is shivering, and shivering produces more of heat. Muscles are contracting, more heat is produced. When more heat is produced, this causes increase in body temperature. What about vasoconstriction? Blood vessels are constricting in the periphery to the skin. If you have vasoconstriction, vasoconstriction reduces the blood flow. Vasoconstriction decreases the blood flow. If blood flow decreases, less blood is only reaching your skin. So when there is more blood flow, it is a method of heat dissipation from the body. If blood flow is less, it is conserving heat. So there is conservation of heat. This would conserve heat. The more you conserve heat inside your body temperature will increase. So this results in increase in body temperature. Yes. So option A, thermogenesis increases your body temperature. Option C, activation of posterior hypothalamus increases body temperature. Peripheral vasoconstriction also increases your body temperature. So what about this option B, where inhibition of neuron of sympathetic chain of the posterior hypothalamus? Yes, if posterior hypothalamus is inhibited, or the sympathetic chain which supplies the posterior hypothalamus is inhibited, posterior hypothalamus, when there is an increased body temperature, this will lead to decreased body temperature. All other options are increasing the body temperature. Increase in body temperature cannot cause further increase in body temperature. It will only cause decrease in body temperature. So increased body temperature will lead to inhibition of the posterior hypothalamus, thereby as a control system. So this is decreasing your body temperature. So the more appropriate answer would be option B, inhibition of posterior hypothalamus, because all other options are further increasing the body temperature. So this is about the control system inside the body temperature regulation. The second question, trypsin suppression is done by which of the following? So let's quickly learn about what is this trypsin. Trypsin is produced by pancreas, not trypsin exactly, it is trypsinogen. Trypsinogen is produced by the pancreas, and this trypsinogen is released into the duodenum. So from the pancreas, it enters into the small intestine, your duodenum. And inside the duodenum, this trypsinogen is converted to trypsin by enterokinase enzyme. So this happens only in the duodenum. Trypsinogen has to be converted to trypsin, and trypsin is going to go for digestive processes. This should happen in the duodenum. But sometimes what happens, some of this trypsinogen in the pancreas itself, it can be converted to trypsin. Actually, it should not happen. If accidentally this happens, trypsin is a digestive enzyme. This will lead to auto-digestion of the pancreas. This is very dangerous. Auto-digestion of the pancreas. That can lead to pancreatitis and so many pancreatic disorders. This should not happen. But if accidentally it happens also, this trypsin can be neutralized by pancreatic trypsin inhibitor. Pancreatic trypsin inhibitor. This would inhibit the trypsin, thereby preventing auto-digestion. So normally, trypsinogen is produced by the pancreas, released into the duodenum, small intestine. In the duodenum, trypsinogen is converted to trypsin, and that will go for digestive process. But in case if there is any accidental conversion of trypsinogen into trypsin in the pancreas itself, that might lead to auto-digestion of the pancreas and pancreatitis, and that can be prevented by pancreatic trypsin inhibitor. Normally itself, pancreas produces pancreatic trypsin inhibitor. This will inhibit the trypsin, and therefore auto-digestion of the pancreas can be inhibited. So trypsin suppression is done by which of the following? We can go with pancreatic enzyme. To be very specific, pancreatic trypsin inhibitor. What about the other options? Obviously, we know the functions of other options. Salivary amylase. Salivary amylase helps in carbohydrate digestion. Carbohydrate digestion. Gastric acid contains gastric acid. Gastric secretions contain a lot of substances. The most important one of gastric secretion is gastric acid, HCl, which helps in digestion of food. Bile. Bile helps in emulsification of fat. Bile helps in emulsification of fats. So obviously the other options are not related to trypsin, only pancreatic enzyme, pancreatic trypsin inhibitor. Only this one is related to trypsin. So that's about the two questions that were asked in physiology. Thank you so much for joining with me in this session. So I complete physiology with this. Over to anatomy questions by Dr. Mona Lisa. Thank you.
Okay, students, just wait. Okay, students, just wait. Be seen. Long screen. Okay. So, is the screen visible? Everything is fine. Please let me know, dear students. Is the screen visible and everything is fine? I will just check with the students. Okay, so yes, screen is visible and everything is fine. So my dear students, okay, so I just want to know, how was the exam firstly before starting the anatomy? Yeah, good evening, Pooja, good evening, Alia, Zafar, everyone. So those who are live. Yeah, so I'm going to discuss all the anatomy MCQ. I think anatomy was good, all good. Oh yeah, very good. So I think anatomy questions were moderate and it was easy and everything was already taught in the class. So I think the question was easy and I feel that everyone must have got good set of questions being right. So let's discuss it. Or if you want any correction to be made in the options given or in the image, or you want to add on anything, you can just add on. Okay. My dear students are telling difficult. Yeah, one or two few questions were confusing, but then also don't worry, I am here to solve it. Okay, one of the student is telling anatomy was entire from your class. So it was so nice to hear it. So let's start solving it. Okay, dear. So let's start. So let's start with the INICET recall 2025 anatomy sessions. Okay. I think, okay, wait, just wait, students. I will just check with the, there is slight lag. So let me just check. Let me just check, dear. Okay, there is slight lag. So I will just take 30 seconds and I will just check the net connection. Okay, dear. One minute. Please wait for 1 minute. 1 minute, wait. Wait. Net is an issue. No, it is not. मेरा screen यहाँ पे आ नहीं रहा. Okay. Sound है या नहीं वो check करने दो. Hello, am I audible? Hello, I am audible. Hello, I am audible. Okay, so this was the first question. So let me start with the first MCQ. This was the first MCQ. Okay, so this was question. This was the first MCQ. A 60-year-old male presented with diplopia, inability to abduct the right eye, medial rotation of the right eye, and numbness in the forehead and cheek region. So MRI reveals aneurysm of internal carotid artery with cavernous sinus. Which of these structure is most likely affected? The options are ophthalmic branch of trigeminal nerve, abducen nerve, trochlear, and oculomotor. So what you have marked here? So actually, this is again a confusing question. Why? I will tell you why the question is confusing. But according to the collection of the words from the students only, we have made this MCQ. So what I think, what was confusing here is the aneurysm of internal carotid artery is mentioned. So what is the most important part which is mentioned here is aneurysm of internal carotid artery, which is inside the. Yeah, very good, dear. Very good. So yes, okay, thank you, dear. That the mantra is yeah, but this was, I would like to explain, and I would like what you have marked as a right answer. So those who have appeared for examination, please tell me what you have marked it right. Whether you have marked ophthalmic branch of trigeminal as the right answer, absent trochlear or oculomotor. So yes, as I can see that LR6 and SO4 is giving innervation to lateral rectus and superior oblique muscle. So both of these are exactly the hint. And other important point is aneurysm of internal carotid artery. So I think similar kind of MCQ and similar kind of the cavernous sinus aneurysm and involvement of internal carotid artery and abducen nerve was done. So I will also show you the image of the class which we have taken. So basically यहाँ पे दो doubt हो रहे हैं. One is that the medial rotation of right hand, numbness of forehead and cheek. So that means if I am talking about forehead areas and the area sensation around the eye, that is done by ophthalmic branch of trigeminal. So that can be involved. But if I have to choose one correct answer among whole of the option, aneurysm of internal carotid artery involved inside cavernous sinus will involve abducen nerve, that is the sixth cranial nerve. And so I'll go with abducen cranial nerve. Okay, so yes, many many students has marked right, that is C. Yeah, C. Okay, B, C, D, E is the option. Okay, C is the right answer. Very good. So those who have marked C as the right answer has got absolutely correct answer, because two options are visible to be correct here. That is the ophthalmic branch of trigeminal nerve and the abducen nerve involving lateral rectus muscle, which is causing abduction of the eyeball. But if I have to choose one, I will go with abducen nerve, because inside aneurysm of internal carotid artery is involved. And ma'am, please tell us the answer directly. We are tired. Okay, I got it. So the students are telling tired by listening too much of the session. Don't worry, I will go slow. I will come to that correct answer only. But I just want to correlate with the screenshot which I have taken from my lecture. So you can see I have taken the screenshot of my lectures. And if you remember, I have explained that this is ICA, internal carotid artery, and this arrow marked nerve is the sixth cranial nerve, if you remember. And lateral rectus muscle was involved. So this is exactly from the class notes. Yes, this was exactly from the class notes. So this is exactly the correct answer, and this has come for the INICET exam. Very good. And you can see here, I have also explained this image with you, and I have told you about the nerves related. As you can see in the lateral wall, the third, fourth, sixth cranial nerve, and inside we have internal carotid artery and the sixth cranial nerve. So that is the right answer. Okay, my dear students, come to the next question. So there was, okay, so let's come to the next question. The arrow marked structure shown below. So the next question is the arrow mark structure shown in the image below shows which of the following structure? Okay. So the arrow marked structure in the image below shows the wall of which of the following structure? Shows the wall of which of the following structure? So I just want to enlarge this image. So my dear students, I have enlarged this image, which is showing the sagittal section of the brain, as you can see here. And the arrow mark structure is showing which area of the brain. So sagittal section of the brain, coronal section of the brain, transverse section of the brain was completed in the neuroanatomy session. And I think most of you must have marked it right. So can you tell me which area is this? So very easy. This is the corpus callosum. This is the largest commissural fiber. No doubt about this. This is corpus callosum, the largest commissural fiber. And below that, we have got the lateral ventricle. So which ventricle is this? This is the lateral ventricle. So this is LV, lateral ventricle, and this wall, the wall is exactly formed by septum pellucidum. Below it, we have got the fornix. So this is what? This is the fornix. So this part is F for the fornix. So this is fornix. This is the fornix. And we have got the septum pellucidum, and this is the lateral ventricle. So the right answer is lateral ventricle. ओके कुछ नहीं समझ में आ रहा है, सिर्फ आंसर्स जानना है. So yes, I can understand, my dear. Please just cooperate. I can understand you are very tired. You don't want any kind of explanation. Just tuck ये है answer. But actually it has to be proved also, no, so that you can correlate कि आपने correct answer लगाया है या आपने wrong answer किया है. So basically this is lateral ventricle. So the right answer will be this is LV. This is the lateral ventricle. Is it okay, everyone? So have you marked as lateral ventricle? Please let me know, my dear students. I have explained this I have explained, and I think this is again an image which has been taken from from my explanation which we have done in the class. So this is the lateral ventricle, and this was the image which I have explained in the class. So this is also the screenshot taken from my class lecture. So you can see the corpus callosum part. Below it you can see the LV, the lateral ventricle. Okay, so few students are telling no problem, ma'am, please explain. Okay, so few students are telling not explanation, just the correct answer. So this is this is the corpus callosum, and this area is the LV, because which is lying below it, lateral ventricle. And also many times I told you, go through the sagittal section, go through the coronal transverse section. This is favorite question for the INICET exam. Done? Okay, so can we move to the next MCQ? My dear students, can we move to the next MCQ? Next MCQ. Now, this is another sagittal section of head and neck. So one of the image which we have just completed was the sagittal section of the brain, and this is the sagittal section of head and neck session. And you have to tell which of the following muscle in the image shown are supplied by vago accessory complex except. Now, the first thing which I want my dear students to tell me, what do you understand by vago accessory nerve? Vago accessory nerves. So vago accessory nerve means we know that vagus nerve is the 10th cranial nerve, and the accessory nerve, the 11th cranial nerve, is having two components. It is having the spinal part and it is having the cranial part. The cranial part of the accessory nerve runs along with the vagus nerve. Okay, so when I'm talking about the vagus nerve, the vagus and the cranial part of accessory nerve is growing together. If you remember my class of cranial anatomy, I told you many people has got the habit of keeping chamchas like this. We have studied at that time. So the vagus nerve का जो follower है वो है cranial part of accessory. So most of the muscles of pharynx and the muscles of soft palate, pharynx and all is supplied by the vagus nerve carrying the fibers of cranial part of accessory. Now in this sagittal section there is BCDA. So let me just enlarge this image. So I'm just enlarging this image so that you can have a proper idea of the structures being seen. So basically now C, if I'm just talking about the C, absolutely correct answer. So again, C is the right answer. I will tell you why. Because which muscle is C? Which muscle is C, my dear student? The muscle which is marked C is genioglossus muscle. So this is the bulkiest muscle of the tongue, which is called as the genioglossus muscle. And the genioglossus muscle is supplied by hypoglossal nerve, the 12th cranial nerve. So obviously the right answer will be genioglossus muscle, the C-marked structure, because it is not supplied by vagoaccessory complex, it is supplied by the 12th cranial nerve. Now comes, why not the other muscles? So like B is the uvula attached to the soft palate. Uvula so actually this is not exactly in the section. They are not exactly showing the muscle. They are showing the area. So A is the area of nasopharynx, as you can see. And if I talk about B is the area associated with the soft palate. And D is the area lower down in the pharynx, laryngopharynx area, laryngopharynx area. So basically, I would like to show you, this was the image. If you remember the class, this was the societal section. So I have included 2 societal section from my class notes. So this was the image of the class notes in which I have shown you all the areas. So we can see the nasopharynx area, we can see the laryngopharynx area, we can see the soft palate, we can see the opening of auditory tube which was marked. So here G for the genioglossus muscle, and this is supplied by not by vagoaccessory nerve. So that is the right answer. Okay. If you remember, this was exactly taken from my class notes in which I have explained the societal section of pharynx, larynx, mouth. And here you can see the tubal opening and tonsil. We can see the nasopharyngeal tonsil. We can see the genioglossus muscle here, and we can see the nasopharynx, oropharynx, and laryngopharynx. So if we have to mark the right answer, C is the right answer. I think the students have already marked it right, so a thumbs up goes for them. Can we move on to the next MCQ, everyone? Okay. Now coming to the question number 4. So if I talk about the question number 4, the composite image. So if I talk about this composite image is shown below, which is consist of the bones of head and neck region, and which is not a derivative of first pharyngeal arch. So this, from the very beginning when they completed the session, many of the students in the group was telling about this MCQ. So basically in this MCQ, yeah, this was there. So A, B, C, D is marked, and A, B, C, D is the bones, and we have to know which is not a derivative of first pharyngeal arch. So for this, I will first let you actually, for this, I will first let you to know the derivatives of the derivatives. So when I am talking about derivatives of the first pharyngeal arch, I have marked maxilla. No, bache, maxilla is not correct. Let me explain it. Okay. First pharyngeal arch bones are maxilla, part of mandible, malleus, incus, zygomatic, and part of temporal bone. So these are the bones which are derived from the first pharyngeal arch. Maxilla, mandible, malleus, incus, zygomatic, and part of temporal bone. Okay. The ethmoid bone, if I talk about the ethmoid bone, along with the frontal and sphenoidal bone, they are the part of neurocranium, and they are derived from NCC, neural crest cells, from the cartilaginous capsules ossifying and then forming. So basically they ossify, but not specifically they are the derivatives of first pharyngeal arch. So that means we will mark ethmoid bone as the right answer. Now, this is exactly from the class notes which I have included. This table I have completed in the class notes, in which you can see the first, second, third, and fourth arch derivatives. So we will conclude on the first arch: malleus, incus, mandible, zygomatic, palatine, temporal, sphenomandibular ligament, and the ligament of malleus, anterior ligament of malleus. So definitely ethmoid bone is not included. Now coming to the images. So you can see the first image. What was option C? Option C image is temporal bone. So actually squamous part of temporal bone, not the styloid portion, but squamous part of temporal bone is derived from first pharyngeal arch. So it can't be the right answer. Zygomatic bone also is derived from the first pharyngeal arch. So the A image was zygomatic bone. If I talk about B image, it is the maxillary bone. What is G? If I talk about B image, it is the maxillary maxilla bone. And if I talk about the D image, it is the ethmoid bone. Which bone is this? This is the ethmoid bone. So basically, if I'm talking about the right answer, we will definitely go with the ethmoid bone. That is the D option is right. Ethmoid bone is the D option, and D is the right answer. So D. So here B, D. So basically, you can say the image which is showing the ethmoid bone is the right answer. The image of ethmoid bone is the right answer. Is it okay, everyone? The image of ethmoid bone is the right answer. Everyone, have you marked ethmoid bone? Let me know, is my dear students marked ethmoid bone? So ethmoid bone is the right answer. Let me just check. Okay. Okay. Now coming to, okay, so coming to the next MCQ. Question number 5. A 7-day-old baby is diagnosed with a case of patent ductus arteriosus. Patent ductus arteriosus. He is being operated for the ligation of ductus. The surgeon has to be careful about which of these structure is injured during the surgery. Okay, so right recurrent laryngeal nerve, left recurrent laryngeal nerve, left vagus and left phrenic nerve. So what you have marked? So this question I have done in the PCT also. So we have included this question in the PCT class. And I think most of you must have marked it right. So basically the diagnosis is the case of patent ductus arteriosus. And we know the left recurrent laryngeal nerve wind around the ligamentum arteriosum. So it will be the left recurrent laryngeal nerve as the right answer. So have you marked B? So yes, my dear students have marked B. So again, a thumbs up goes for them. Thumbs up and clapping goes for them. Very good. So B is absolutely right answer. So I think similar kind of question, that is the derivative of left pharyngeal arch, sixth pharyngeal arch. This image-based question I have included in the PCTs and subject-wise test, and the right answer for this was ductus arteriosus. Same way for the recurrent laryngeal nerve, this is the notes from the class in which we have discussed about the winding of left recurrent laryngeal nerve around the arch of aorta, around the ductus arteriosum and ligamentum arteriosum. Done? So we have got the right answer here. So definitely we have got the right answer here. Can we move on to the next MCQ, everyone? Okay, so we have done this and now we are moving on to the next MCQ. Question number 6. Pharyngeal tonsil is located at. So this, so multiple times I have told you. What is the location of nasopharyngeal tonsil? What is the location of nasopharyngeal tonsil? And nasopharyngeal tonsil is located in nasopharynx. Pharyngeal tonsil is located in nasopharynx. Have you marked it right, my dear student? So nasopharynx is the right answer. So this was directly from the notes, and this was the most easy question, I think, of all the INICET exam. This was no, pharyngeal tonsil, dear. Oropharynx, we will have the palatine tonsil. Posterior part of the tongue will have lingual tonsil. So nasopharyngeal tonsil and tubal tonsil. Both nasopharyngeal and tubal tonsils are present in the nasopharynx. Yeah, so many of the students like Sweeties, Snehal, everyone has marked. Alia, everyone has marked A as the right answer. So absolutely a thumbs up goes for you. No worries, don't clatter that what you have done. What is done is done. Now just be positive and wait for the result. Okay. So this was the image from my lecture which I have taken. And in this, you can see this is the pharyngeal. So see here, this is an image from my lecture. This is pharyngeal tonsil and this is the location of nasopharynx, which we have done in the class. Okay. Coming to the next. So please help me from this question. Question number 7. Which of these structure is not a derivative of first pharyngeal arch or mandibular arch? Or the question was, which of these is the first derivative of mandibular arch? So can anybody guide me? The few students has told me the question was, which of this is the not the derivative of mandibular arch, that is the first pharyngeal arch, or which is the first derivative of mandibular arch? So what was asked? Can anybody write in the message what was asked? Not the derivative of mandibular arch or first derivative of mandibular arch. So don't worry, I will give the answer of both. If the question was asked about the first derivative of mandibular arch, then it will be incus and malleus. Also, okay, malleus and incus. So it will be malleus and incus. Why? Because mandibular nerve and Michel's cartilage all are derivative, but if it is directly asking the first and the exact derivative. Okay, first and exact derivative. So basically, I will tell you why I would like to mark this as the right answer. So basically, coronoid process will not be the right answer as it is formed by intramembranous ossification around Michel's cartilage. Okay, and Michel's cartilage is obviously the cartilaginous rod of the mandibular arch, but it is not about the adult derivative. It is actually, it is not an adult derivative. So it is formed and further it forms incus and malleus. Okay. So if we go like that, mandibular nerve is a branch of trigeminal nerve, and it is actually not structural derivative. It is the nerve. It is the nerve of first arch. It is not the structural derivative. Micus cartilage is formed from the mandibular arch, but it further forms incus and malleus. So if I have to go with most correct, actually this was a confusing question, but if I have to go most correct, I will go with malleus and incus. Is it okay? So malleus and incus will be the right answer. Yes. Okay. Malleus and incus. If you have marked malleus and incus, so that is the right answer. Okay. I have given the explanation. Mickel's cartilage is not directly the first derivative, but rather cartilaginous structure, which later forms malleus and incus. Okay. So that is Mickel's cartilage is obviously the first derivative form structure, but it later forms the adult derivative malleus and incus. So this was a confusing question. So if I have to, so both malleus, incus, Mickel's cartilage will be right, but if I have to choose one, I will go with malleus and incus. Okay, and this was the image taken from my lecture where the first derivative structures. So see here, first derivative structures are all marked here. So adult derivative, I think you should go with the exact question. If you remember, if it was asked adult derivative, first adult derivative from the first pharyngeal arch, it's malleus and incus. If it is asked the cartilaginous derivative from the first of the mandibular arch, then it will be Mickel's cartilage. Okay, then it will be Mickel's cartilage. Okay, now coming to the next question. Okay. Then Mickel's cartilage, if first form structure. So first form structure they have asked, then Mickel's cartilage. First adult derivative they have asked, then malleus and incus. Okay. Okay, is it okay? Everybody okay with this? Okay. First formed structure, then Mickel's cartilage. If the literature is telling first formed or first formed structure, then Mickel's cartilage. But if it is telling first adult derivative, then malleus and incus. I think I have so many times I have come with this explanation. Let's come to the next one. A patient presented drooping of eyelid, constricted pupil, inability to sweat on one side. On clinical examination, ptosis, meiosis, and hydrosis consistent with Horner syndrome was diagnosed. Damage to which of the following structure is same except. So damage of which of the following structure is same exactly what is written like Horner syndrome except. So basically cervical sympathetic chain, internal carotid artery, sympathetic plexus, superior cervical ganglion, all will have the features corresponding to Horner syndrome, and in that case except it has asked. So abducer nerve is the best answer. It is the best answer here. Okay. Okay, dear. Yes. Okay. One of the students is telling why mandibular nerve. So it's Ria. Okay, Ria, I will tell you why mandibular nerve we will not mark. Mandibular nerve is a branch of trigeminal nerve, and it innervates the structure of first pharyngeal arch. Okay. So it is also the nerve of first pharyngeal arch. So it is not the structure which is exactly derived from first pharyngeal arch. Got it? It is the nerve of first pharyngeal arch, but it is not the structure derived from the first pharyngeal arch. So we'll not mark mandibular nerve. Is it okay, Ria? Is it okay, Ria? Okay. Okay. Now, cervical sympathetic chain from the Pankos tumors leading to triad. So basically, in that case, if you have to go with most correct answer, if it was not, so basically the option was similarly like that. If we are talking about the most correct associated structure, then cervical sympathetic chain can be there. Okay. Cervical sympathetic chain can be there if it was asked like that. Okay. Now coming to the question. So I am showing you the similar kind of question I have explained, in which I have talked about the Horner syndrome and the deviation of eye laterally downwards associated with also ptosis and the similar kind of involvement of structure. Most likely the tumor is involving with structure. So I think you have similar kind of question I have explained prior. So this is same from that explanation. Now, the next question is which of these? Okay, then go with the cervical sympathetic chain. Okay. Now, next question is which of these is correct about temporal branch of facial nerve? Don't worry, students. We will have the entire exactly correct option and correct literature of the question. So still we are forming the question and the option. So you will get a detailed of INICET explanation. This was the recent what I have gathered from the students. So which of these is not correct about the temporal branch of facial nerve? So what you have marked this? What you have marked for the question number 9? Which of these is not correct about the temporal branch of facial nerve? Medial to the arch supplying occipitofrontalis, 2 centimeter anterior to external auditory meatus, pass through deep. So Frey syndrome is not because it involves auriculotemporal nerve. The correct and the most correct answer is 2 centimeter anterior to external auditory meatus, B. Now see here, position related to the external auditory meatus, the temporal branch of the facial nerve is approximately 2 centimeters in front of it. So this is the most correct answer which you must have marked. Okay, so these are the notes from the class which I want you to show, and you can see how the facial nerve was traversing inside the parotid gland and how its terminal branches were coming out. And also I have explained about the lesion at the different level of the facial nerve. Other than that, if you are talking about the relation of external auditory meatus, see here, this is the external auditory meatus, and you can see this is the temporal branch of facial nerve. So this relation was important. This was the image which was explained in the class. So it is traversing 2 centimeters. So the correct answer is 2 centimeter anterior to external auditory meatus, the facial nerve temporal branch passes. So this was the image from my class notes, and this was asked in the examination. So I think if you have gone through, ma'am, can you explain facial nerve? Yes, definitely. See here, all the options. So yes, definitely, Aryan, for all the option, I am going to explain this. So see here, facial nerve medial to the arch. So if I talk about medial, so why the other options are wrong? Medial to the arch supplying occipitofrontalis muscle is correct. So basically, if I am talking about the nerve, it is not me. So basically, if I am talking about zygomatic arch, the nerve is crossing superficial to it. So the nerve is crossing superficial to it, not exactly medial to it. So this will be the wrong option. Passes deep to temporal fat is also wrong. If I am talking about the temporal branch, it courses superficial to temporal fascia, and it is just deep to the subcutaneous fat. And so basically it is not very deep. So if you remember, I have shown you an image and in which the piecemeal dissection of parotid gland is done, and in superficial plane is the facial nerve. Next plane there is the retromandibular vein, and after that we have got the arterial plane. So we can't say that facial nerve branch is very deep in the temporal fat. So this is also not correct. Damage to Frey syndrome is absolutely wrong. So damage to Frey syndrome is also not correct. Why? I will tell you, because Frey syndrome causes gustatory swelling, and it is seen in the damage of parotid gland involving auriculotemporal nerve. So I just want you to see this image. This is auriculotemporal syndrome, which I have explained in the class. So this is screenshot from my class. So this was also the wrong option. So yes, done with the session. So I'm done with the session, and hope the session explains you about all the question. I think anatomy was moderate, and many of you. Okay. Okay, dear. So we have done with this, and any corrections of the options and the questions, we will frame it once again. And I think this is giving you the idea of the correct answer. All the best and study. So don't take tension, and hopefully and be optimistic about your result. Thank you. Thank you so much.